Good evening to all. We are going to start our online CME on fluid and electrolytes in children, which is a basic topic which is required for everyday practice from peripheral center to a tertiary care hospital. Now, it is a novel academic initiative from West Bengal Academy of Pediatrics to cover all the practically oriented basic topics in every month, and like this way, for mainly for the junior doctors, the residents, and the practicing pediatricians. So with these lines, I shall now request Professor Kalpana Datta Madam, who is Head of the Department of Pediatrics, Medical College, Kolkata, and President, West Bengal Academy of Pediatrics, to welcome our esteemed faculties and the delegates. Over to you, Madam.
Thank you, Dr. Mihir. Good evening, everyone. I welcome you all on the behalf of West Bengal Academy of Pediatrics 2023 in this digital platform. This is the first workshop of West Bengal Academy of Pediatrics in this year, and this will be followed by many series of workshops, as already explained by Dr. Mihir, of clinical importance. And this whole idea is from our most dynamic and academic joint secretary, who must be knowing none other than our Professor Mihir Sarkar, his brainchild and his idea to do this type of workshop in a number of series. We will, I think, at least we can cover the 10 topics. Already January, February is gone, it's the March. So we'll try to cover the 10 topics. And we are really lucky to have a galaxy of faculties, and we have with us the esteemed faculty like Dr. Professor Arvind Bagga sir, and Dr. Jayashree Muralidharan with us. I'm really lucky to welcome sir from core of my heart. I welcome all the participants, and I'm really happy to see the overwhelming response of the participants. And I'm sure we will be enriched by the all esteemed faculty's deliberation. And you clear your doubts, whatever the doubts you have, just clear it either writing in a chat box, or you can send it in the WhatsApp. In future also, we'll communicate in the chat, WhatsApp or mail. And enjoy this academic session the coming 3 days, and empower and enrich yourself. Thank you. And again, I welcome you all. And I think Dr. Indrandil has not joined. So over to Dr. Shapun Roy, who is our scientific chairperson of West Bengal Academy of Pediatrics 2023. I am handing over the platform to Dr. Roy.
Thank you, Professor Datta, for your kind words and initiations of this workshop. I think all the faculties and the delegates, those who have joined, will be definitely, we are giving you a warm welcome, and all the delegates will be very much benefited by this type of workshop. And West Bengal Academy of Pediatrics is determined to showcase the academics properly in this whole year. And we are just rolling the stone by our very dynamic Professor Mihir Sarkar. And obviously, I must convey my thanks to Dr. Sumantra Raut and also Dr. Rohit Bhomik. He has done a splendid job in, he will be noting on the final day, the app for this question quiz. And I'm also very overwhelmed by the gesture that Professor Arvind Bagga, the pioneer of pediatric nephrology, he has joined, and he will be giving the opening comment as well as the lecture. So welcome, sir, and from core of our heart, we are really honored that you have joined in this session. And please give your blessings that in future West Bengal Academy of Pediatrics may do such academic activities in future. So with this, I will hand it over to Dr. Mihir Sarkar, and I will request Professor Arvind Bagga to give his opening comments. Sir, over to you, please.
Thank you, Dr. Roy. Thank you once again to the entire West Bengal Academy of Pediatrics for inviting me for this excellent online symposia, which, as you have just said, would be one of the, which is in fact, the first ones in of a number of such sessions that are likely to follow. I'd like to thank the chairman, the chairperson, Professor Datta of the West Bengal Academy, the president of the West Bengal Academy of Pediatrics, Dr. Roy Yossel for your kind words, Dr. Chaudhary, Dr. Mihir Sarkar for organizing this meeting. And we all understand, that clearly fluid and electrolytes really forms a basis of a lot of practice for virtually all pediatricians. Just like growth and development, immunization, infectious diseases, fluid electrolytes is something, that is cross-cutting across specialties. Whatever work you are doing, as a pediatrician, as a specialist, one does need to master this area. And I'm sure, that with the topics that are being covered over the next 3 days, especially on the basis of fluid therapy, the various disorders of electrolyte disorders, as well as the role of fluids in various complex diseases. This workshop will really be a trendsetter for future. I think it's a very important topic that's being done. It's a difficult topic as well, but I think the fact that it's being done is, and I would really like to congratulate the West Bengal Academy of Pediatrics, and I bring with me best wishes from New Delhi. And thank you very much for the invite, and I'm very happy to be here. Thank you very much.
Thank you so much, sir, for your words of encouragement, and we have no words to express our gratitude that you have joined with us today. Now, with these words, I think Dr. Indranil Chaudhary has not joined, our secretary, sir. So we'll start our next academic program. For today's academic event, Dr. Sumantra Raut will be the coordinator to control the program of today. So over to you, Dr. Sumantra. Please conduct the next academic sessions.
A very warm welcome from WAP to all the delegates and all my senior teachers. Thanks to WAP for providing us an optimum platform for this. And at the utmost, I thanks to my own mentor and the father figure in international platform of pediatric nephrology, our own Professor Arvind Bagga sir, to agree to be a part of this one, to initiate these academic sessions. And today our first talk will be one of the most debatable topic which we day-to-day face in our regular ward, even if in general pediatrics or in the pediatric nephrology, or even the adults face in the case of dealing a child with nephrotic syndrome. So our talk today will be on the presentation of how to manage the fluids in case of a patient with nephrotic syndrome. So on behalf of sir, probably I am going to move the slide. So there may be some technical glitches. Excuse me for that. So can we welcome our sir, our mentor, Professor Arvind Bagga, to deliver his first speech. Over to you, sir.
Thank you, Sumantra. Again, as I said, it's my privilege to be here and to be able to talk to you on this important topic. We do know that the management of fluid therapy in nephrotic syndrome is at times difficult. So I'll be this will be a brief talk, but there may be some repetition. So please, and I'll really try to talk to you about the very principles on how to manage the fluid status, very briefly about diuretic use, and we hope that there can be questions that can then be addressed. So we know that edema in nephrotic syndrome, the classic hypothesis, which I'm sure all of you have read as undergraduates and even postgraduate students, has been the underfill hypothesis versus the overfill hypothesis. The underfill hypothesis is very well known to all of us. We know that because there is hypoalbuminemia in nephrotic syndrome, the Starling forces get disrupted, and thereby you have extravasation of fluid into the interstitium. And because there is extravasation of fluid into the interstitium, the intravascular volume would get depleted, thereby resulting in activation of the renin-aldosterone axis, renin-aldosterone-angiotensin axis, resulting thereby in sodium and water reabsorption that would cause edema. So this is the classic underfill hypothesis that we have all read in physiology. In addition, there are a number of problems with the underfill hypothesis, and over the last 3 decades or so, maybe even longer, there has been increasing data that apart from underfill, there is a primary overfill, there is a primary sodium retention in patients with nephrotic syndrome. This could be a primary problem in the tubules, in the epithelial sodium channels. It could also happen because of some other neurohumoral factors that we don't understand that well. Increased capillary permeability that we know happens in nephrotic syndrome. So primarily, there's a problem is not in the albumin levels, but there's primarily a salt retention in these patients. And because there's salt retention, the intravascular volume gets expanded. So this is an expanded volume now compared to the depleted volume in the previous underfill hypothesis. That results in increased hydrostatic pressure, extravasation of fluid as per stalling forces, and thereby resulting in edema. So clearly, and both hypotheses have their, and it's not to say that a patient who has underfill cannot become an overfill. So the same, so both the mechanisms could happen in the same patient at different points in time. Now, whenever we evaluate children, just stay on the same slide, Sumantra. Whenever
Yes, sir.
we evaluate children, and whenever test studies are done, it's been seen that underfill is clearly more common than overfill in children. This is slightly different in adults, where overfill is perhaps as important or maybe slightly more important than underfill. So most children, who present to you in a relapse with nephrotic syndrome are in a volume depleted state. So keep this thing in mind, and most of us would keep this fact in mind that in steroid sensitive nephrotic syndrome, whenever you have a relapse, even if you've got massive edema, there is a state of intravascular volume depletion. Compare this to a patient who has a primary glomerular disease, like say membranoproliferative GN, or say an acute GN, where the edema is secondary to overfill. So I think one needs to distinguish, and clearly, this really becomes our step one in evaluating these patients. Next slide, Sumantra.
Yes, sir.
Now, the second point here is that edema is a problem. We all understand that, as clinicians. And edema, not all patients in nephrotic syndrome, but some patients in nephrotic syndrome, they may require some sort of therapy. Can we classify edema based on the pattern of amount of weight gain? The guidelines of the Indian Society of Pediatric Nephrology that were published in 21, and previously the Japanese guidelines, we have tried to define or try to classify edema as mild, moderate, or severe based on a less than 7% increase, 8 to 15% increase, and more than 15% increase of body weight over the baseline. Again, this definition is rather empirical and there's nothing cast in stone here. Other people have used a definition of less than 7, 7 to 10, and more than 10 for mild, moderate, and severe. Suffice to say, that the lower the serum albumin level, the more will be the edema. And patients who have severe edema usually have very marked hypoalbuminemia that's below 1.5 gram per deciliter. One thing that all of us must keep in mind is, that the way we estimate albumin levels in our country, we tend to overestimate albumin levels by something like 0.5 gram per liter, because the test that we use is the bromocresol green test, or the BCG, compared to the bromocresol purple test that's used all over the world. That is clearly 0.5 gram per deciliter lower. So whenever you are seeing albumin level in your lab, first look at the method, whether it's a BCG or a BCP. If it's a BCG, keep in mind that you are estimating albumin compared to what the true albumin is. So that's one message that I would want to give. The next message, as I said before, so we need to figure out clinically whether the patient has underfill or overfill. So assessing the intravascular volume status, especially in patients who have got moderate to severe edema, is imperative before embarking on therapy, especially before embarking on diuretic therapy. You need to be relatively sure, whether there's a state of underfill or overfill. Next slide. Now, how do you determine whether there is the intravascular volume is depleted? And these two boxes that you see, on the left, you have the clinical features, and on the right, you have certain laboratory features. Abdominal pain is a very important marker of during a relapse, and it really reflects mesenteric ischemia. So having a child with abdominal pain, vomiting, not feeling well, lethargy, and so on, they're very classic signs of intravascular volume depletion. Not to say that they cannot happen in other conditions. They can happen, but whenever you get this, please keep this in mind. A prolonged capillary refill that you all know how to look at, cold, clammy extremities, which may be variable. Not everybody may show cold extremities. On the other hand, please keep in mind that children who have edema, which is massive, they may anyway have cold extremities. So cold extremities may be a rather subjective sign that one should be careful with evaluating. Tachycardia, the blood pressure, and you know that the complications of intravascular volume are well known. So you can really have children going into shock. On the other hand, you may even have acute kidney injury that may happen due to intravascular volume that's depleted. And then you may even end up getting venous thrombosis, which may happen in the limbs, in the brain, and so on. Do keep in mind, that we have not written urine output as a marker of intravascular volume depletion here, because, urine output could be low in nephrotic syndrome, even without there being a state of intravascular volume depletion. Oliguriasia is quite usual, during a relapse. So you can't really use urine output as a marker for intravascular volume depletion. The laboratory tests that you have are the commonest tests, that we often look at is in fact a high hematocrit. You would have children coming in with hemoglobins of 15 or even 13, which is a bit unusual in our country. And at times we have had even higher hematocrits. But do keep a look at the hemoglobin and the hematocrit. I'm sure these things are all known to you. The ratio of blood urea to creatinine, which is, if it's very high, clearly there is something amiss. There is a hypovolemia. Look at the fractional excretion of sodium, which again should be looked at in an individual who is not on diuretics, who is not receiving IV fluids. Because if somebody is on diuretics or receiving IV fluids, then the FeNA may change. But in a naive patient who walks into your outpatient, and if you're unclear, one could look at the fractional excretion of sodium. The only problem is that the reports take a while to come, and therefore you may often have to wait, which is not possible. So it won't give you a point of care assessment. One test, that's cited a lot is the urine potassium index. And if you can look at the ratio of urine potassium to the ratio of the urine sodium plus potassium on a spot sample, this indicates a state of hyperaldosteronism, which would be a feature of depleted intravascular volume. And if the ratio is more than 0.6, it probably indicates a depleted intravascular volume, again in a state when you are not on diuretics. High PRA aldosterone may not always be available. So while I'm writing it here, it's a test that's often not available. And obviously you can do point of care ultrasound, provided you have the expertise and the experience to be able to look at the decreased IVC diameter or its collapsibility index, or even at the ratio of the IVC size to the right atrium size. So, but then, so clearly focus or point of care ultrasound is important, provided you have the expertise and the experience and you can pick this up clearly. Suffice to say, that children with steroid sensitive nephrotic syndrome who come in a relapse, mostly, they are volume depleted. Next slide, Sumantra.
Yes.
So how do you manage somebody who's volume depleted, who's showing signs, a relapse with abdominal pain and the signs that I just mentioned, or a relapse with GI losses, who looks clearly volume depleted, or somebody who's been given lots of diuretics? So how do you manage a patient who is clearly having edema but hypovolemia? I would obviously discontinue the diuretics because they are not required. As a guide, most societies would say that do not use ACE inhibitors or herbs during a relapse, chiefly because there is a state of underfill, and if you were to use ACE inhibitors or herbs, you may just tilt a patient into acute kidney injury. So just be careful at that point in time. And very often, in fact, what we often tell the parents who are on ACE or herbs for steroid resistance when they go home, we tell them, that if you have diarrhea, vomiting, or if you are having fever, just omit the ACE or herb for that day. Don't take it for those next 2-3 days, because you can really end up precipitating a high serum creatinine. The fluid management in these patients is relatively clear, and quite straightforward. And Yeah, I'll try to answer these questions. Then I'm seeing. Yeah, so isotonic saline boluses are recommended, and yeah, because if you may not always have access to albumin, and very often the first therapy or the first therapy in the emergency would be a crystalloid, and one could give 10 to 20 mils per kg. One could give up to 2 or 3 boluses over, say, the next 1 hour, obviously keeping a watch for evidence of overhydration. A better alternate or after saline boluses could be the use of 5% albumin, which is available now, and in the dose that's given here, again given over 30 to 60 minutes. We prefer to give 5% albumin, because you can clearly give a larger volume than if you were to use 20% albumin, where the volume that would be replaced would be rather small. So 5% albumin is a better idea than 20%, especially in the patient who is in hypovolemic shock. Once the child is stable, once he's better, then one can try, then one can infuse IV fluids and or allow oral hydration, depending on the child's oral acceptance. As well as, if the child is still hypoalbuminemic, one can then give IV albumin. This time you can use 20% and give that more slowly at a total dose of something like 0.5 to 1 gram per kg. So I would recommend, that the initial therapy should be normal saline and or 5% albumin, especially in patients who are in hypovolemic shock, and later shift on to oral hydration, IV fluids, and 20% albumin as required. And there's reasonable amount of evidence for this. It's a recommendation and a 1C recommendation. Next slide, Sumantra.
Again, sir.
Okay. Yeah. So the obviously, that the next important drug, and I'm just putting this slide here, we'll discuss this as we go forward, are the diuretics, that are available with us. And the diuretics would act at different sites. That some diuretics may act at the proximal convoluted tubule. They are not very strong diuretics, but the SGLT2 inhibitors, it's not really a diuretic, but it would lead to loss of, it would cause natriuresis and so on. So then you have, agents working at the proximal straight tubule, and the chief diuretic, that we often use works at the thick ascending limb of Henle, or more distally at the level of the distal convoluted tubule. As is shown in this figure, spironolactone and amiloride and even triamtrene act at the level of the cortical collecting duct. Sorry. And mannitol and tolvaptan would act even more distally. So one should be aware, that various diuretics have different sites of action. The importance of this is, that when you, and I'll discuss this a bit later, that because furosemide and thiazides are acting at different sites in the nephron, their combination would at times be synergistic. And so therefore, there's a reasonable amount of data, and there's a reasonable amount of, it seems a wise idea to combine furosemide with the thiazide, particularly in patients who have got severe edema. And we'll discuss this later. Next slide, Sumantra. So this slide, maybe you can, Dr. Sumantra can circulate later, just gives the dosages and so on. We don't need to go into too much depth. But there is the other thing that's important is, that there is, and most of us are practicing, that there is that when you use furosemide with IV albumin, that when you use IV albumin with furosemide, the diuresis and the natriuresis is clearly higher than when furosemide is used alone. And I'm not going to go into details on how this happens, but I'm sure, hopefully, I think the audience is aware. Sumantra, just go back to the previous slide.
Okay.
Just go back one more slide.
Okay.
Somebody had a comment on this, one more slide, perhaps. Yeah, the one in red, really talks about the features of hypervolemia. Why I put this in red was chiefly because all the other features are those of hypovolemia. In hypervolemia, you would have severe edema, you would have anasarca, you would have hypertension. And because there is hypervolemia, you would have dyspnea. Next slide. Sorry, I missed speaking
sir.
about it. Just carry on.
Okay, sir. Here.
Okay. So clearly, the combination of IV albumin with furosemide has better natriuresis and has better diuresis than furosemide alone. Next slide. So, what is our current paradigm for managing children with edema at disease onset or relapse? So, as just look at the extreme right corner, if there is hypovolemia, we would give normal saline, 10 to 20 mils per kg over 30 minutes. One can use 5% albumin, and I'll try to address the questions later. We can use 5% albumin if somebody is in shock, and then later give oral and IV hydration and IV albumin. Now imagine somebody who is not in hypovolemia. So this does not satisfy the standard criteria. He is otherwise looking well, and you don't think that there is hypovolemia. For mild edema, one does not require diuretics. One can just do a modest salt restriction during the episode of relapse, and we'll talk about this later, and start corticosteroids. And we know that after you start corticosteroids, children would have diuresis happening within the next 4 or 5 days, and they would lose the edema. So for mild edema, you don't require diuretics. For moderate to severe edema, that's more than 7% increase in body weight. These are our Indian Society of Pediatric Nephrology guidelines that were published in 2021 in Indian Pediatrics. One would begin with dietary salt restriction, and we'll talk about how much to restrict later. And the first drug, or the most commonly used drug, is oral furosemide, and the dose is mentioned here. If you're using a higher dose of furosemide, or if you're using furosemide for longer than 2 to 3 days, we would normally add a potassium sparing agent like spironolactone. But do keep in mind that spironolactone on its own is not a very effective drug. So please use the right dose of furosemide, and don't rely on the spironolactone to lead to lead to diuresis. The chief reason why you're using spironolactone is mostly to avoid the hypokalemia. And as I said, most children you don't need to give unless there is marked edema, or if you're using furosemide for a long enough time. Now, then you see over the next 48 hours how the child is doing. So 48 to 72 hours. If the child continues to pass enough urine, and he gets less edematous, it's fine. On the other hand, if he is not responsive, then as I showed you before, one would add a thiazide, and the two thiazides that are used most commonly in our country is either metolazone, and the dose is mentioned here, given twice daily, or hydrochlorothiazide, which is given once a day. And how thiazides work, thiazides, because they block a more distal site, so they are able to potentiate the action of furosemide. And typically what we tell is that you give thiazides, say, about half an hour before, and so on. Now, children, who do not respond even to this, then the next step is to use IV furosemide. Very briefly about furosemide, do keep in mind that when you are using furosemide, I would generally prefer to give furosemide orally, because the area under the curve, when you administer furosemide, is higher than when you give IV. With IV, you get a very high peak, but then the levels also fall down quite rapidly. So clearly, using furosemide, but then on the other hand, if oral is not working for multiple reasons, very often due to gut edema and so on, one would then give furosemide intravenously, and this can be given as a bolus, can be given every 12 hourly. Now, whenever you are administering furosemide, I should have mentioned even before, when you're giving it orally, do ask the parents, is the child passing enough urine? Normally, when you give oral or IV furosemide, the child should pass urine in the next 2 to 3 hours in an amount that's higher than what he was used to passing. Now, the parents say that there has been no response. Next time, the dose has to go up. And this is how you titrate the dose, If IV furosemide does not work, one can even try using an IV infusion, but this should be done in a hospital setting under careful supervision. Now, patients who are refractory to the standard diuretics that we have mentioned here, one can then use albumin. Now, please keep in mind that these are patients who were not hypovolemic, but they are hypoalbuminemic. So in them, you can use IV albumin and in the dose that's shown here over 4 hours with furosemide given at the end of the infusion. in order to enable a diuresis in order to enable diuresis as well as natriuresis. Very rarely in patients who have got impaired kidney function, what would one have to resort to? Isolated ultrafiltration, which is either by dialysis, either by SLED or by hemodialysis. We won't go into details on this here. Next slide, Sumantra. So just reiterating the principles, mild edema, do salt restriction. During the episode of edema, we know that steroids would lead to diuresis, so you don't need to give diuretics. If you have moderate to severe edema, consider using oral furosemide. And I've told you, ask the parent whether the child is passing enough urine and so on. If not, just increase the dose. Patients who are not responsive to furosemide very well could add additional thiazide, either metolazone or hydrochlorothiazide. Could also try using IV furosemide, or one could give albumin with furosemide. And as I showed you in the meta-analysis, albumin with IV furosemide does lead to better diuresis. Do keep in mind, that a child who's got bad nephrotic syndrome or has got severe steroid-resistant nephrotic syndrome, whatever albumin you give, you would tend to get lost in the urine in the next 48 hours. So normally one albumin does not help, and then you need to give multiple albumins. So our policy, at least in New Delhi, is, that we would use albumin sparingly. But when we decide to use, in children who have got albumin levels below say 1.5 or 1.7 gram per deciliter, then we are ready to give at least 3-4 doses, maybe every other day, for a period of about 3 to 4 days or 5 days. One piece of caution: give albumin carefully. And maybe we'll have to also address this in your question answer, because albumin, particularly in a volume overloaded state, could lead to congestive heart failure. Always keep a watch on blood pressure, as well as for pulmonary edema, and give albumin over about 4 hours, particularly when you're using 20% albumin. This is perhaps not that important when you're using 5% albumin. But when you're using 20%, you probably need to give it carefully, keeping in mind that you could have volume overload. Next slide, Sumantra. Now, what are the additional points to monitor? How much salt to give? I saw there was a question on this. One would limit the sodium intake to about 1 to 2 milliequivalent per kg per day, maybe maximum 3 milliequivalent per kg per day, with moderate to severe edema. But don't go overboard. There is no need to restrict normal intakes during remission. Very often, you end up seeing children who have been told कि namak to khana hi nahi hai. Sorry for the Hindi, but you are not supposed to take salt. And parents, just go overboard. So once the edema has gone away, there is no need to restrict sodium thereafter. But I think this is still a point that we would still make in the OPD, that tell parents that reduce the sodium intake for the whole family. We all know, that sodium has its problems. Indians are not very healthy, but as such, biologically we are not, and clearly there is a risk of hypertension for even adults. So I would often use this occasion to tell the parents that reduce your salt intake, but you don't need to have a different salt. We don't need a different diet for your child compared to what you are taking. There is no need to restrict fluids in most children. The exceptions, I thought, which I should probably highlight, is that somebody who has got acute kidney injury, who has edema with a raised urea creatinine, somebody who has hyponatremia, where clearly it indicates that there is fluid overload, there you will need to restrict fluids. Or when you are managing severe edema in a hospital setting, it's really counterproductive to give IV infusion of furosemide and then allow ad-lib fluids, because then it's you're really doing two things counterintuitively. So what we often end up doing is that you tell the parents to restrict the fluids in a child who's got normal kidney function. Don't give too much, so give something like half to 2/3 of the maintenance, especially in a hospital setting. Rarely, if you've got a child who has acute kidney injury, but would one require ultrafiltration by dialysis? Again, all your children who have nephrotic syndrome with edema, one should be monitoring hypertension. I'm again saying the same thing, avoid ACE herbs during a relapse. And children who are fluid overloaded with hypertension, one should initiate therapy with the appropriate diuretic, with the appropriate antihypertensive. Next slide. Yeah, and this is the last slide, essentially. This is really summarizing what we have just said. And these are, just recent guidelines from the International Pediatric Nephrology Association. So their first step is to assess the intravascular volume. If the intravascular volume is contracted, they would say that if the blood pressure is normal, you can rely on 20% albumin. And once the volume is restored, then one could add furosemide, as we just said, But if there is shock, then one can either use saline or use 4 to 5% albumin rapidly. And then once you have a stable patient, then one would manage him accordingly. On the contrary, somebody who has got a intravascular volume that's maintained and there is moderate edema, just use sodium restriction with diuretics. If there is severe edema, they would say that one would use sodium restriction plus fluid restriction, particularly if there's a hospitalized child. Use albumin in patients, and here you would be using 20% albumin along with furosemide. So I'll stop here. I'm happy to answer the questions that are there in the chat box. So Sumantra, I hope I have been able to address.
Yes.
Thank you very much.
Thank you, sir. Thank you for your that much enlightening insight on this topic. This is a very debatable topic, sir, and we keep on confusing within us and within our colleagues also. But the residents are quite much confused in this topic because most of the time we consultants are also not sure of how when to restrict fluid. But after this session, I feel most of the residents and all the practitioners also will be much confident to treat a nephrotic in a hospital setting. So thanks you, sir, once again. And now can I request Sapon sir to just go through the important question in the chat box, and if there isn't doubt, so sir can answer it. There's few questions. Rest of the thing we can deal with online also. Sapon sir,
Yeah,
over to
sure.
you, sir.
So in fact, Doctor.
Yes,
so,
because
yeah.
resident will have much more questions. Sir.
Yeah. I'm happy to answer all. Yeah.
Okay, thank you, sir. Sapon sir.
So you want me to begin, Sumantra? I can begin. So
Okay,
Professor
sir.
Sarkar asked,
Sir answer. Let the sir answer.
Yeah.
Sir, you can.
So Professor Sarkar had asked, children with huge ascites, IVC diameter. Yeah, there are issues. There's going to be difficult to assess. Maybe the collapsibility index is better, but while saying this, even in our setting in the ICU, they do focus. But in our wards, it's tough to do. It all depends on the experience and the expertise. But clearly, somebody who has got huge ascites, it's going to be not very reliable to measure. It would be an issue. Dr. Uma asks, can we consider albumin even in nephrotic with pulmonary edema, but decrease intravascular volume? No, normally when you have pulmonary edema, you would have, a raised intravascular volume. It would be odd, to get pulmonary edema with reduced intravascular volume. But suppose there's clearly evidence of pulmonary edema, I would be extremely cautious. I would be then giving this, would happen in patients with acute kidney injury or say even chronic kidney disease who are under. So there, I would probably have the child have access to dialysis. There, you can dialyze and remove some fluid and simultaneously give albumin for the massive edema. But I don't think this would really happen. Uma, did you have, in case you have another question, you can write to me. But I would imagine pulmonary edema would usually have raised intravascular volume. Is it required to transfuse salt-free 5% albumin? The albumin that we currently have is there are two forms. I think one is the standard salt, which is about 150 milliequivalents. And the salt-free is not really salt-free. I think it's something like 70 to 80 milliequivalents. So clearly, if you have access, one can use the low salt albumin. But as I said, if you have a patient who's in hypovolemic shock, I would prefer to give 5% albumin as a bolus over 20%, because you really can't give too much volume of 20%. Or one could just use saline. Previous slide of hypovolemia, I think I spoke about that. How much oral fluid intake per day? As I said, for mild edema, you don't need to restrict. Moderate edema, you again don't need to restrict. Only for severe edema, if it's in a hospital setting where you are using IV furosemide to ensure diuresis, there one can restrict a bit, but again we don't go overboard. If the kidney functions are okay, Gitanjali, I'm not too much worried. But we do tell the parents ki maybe give about 2/3 the maintenance, but we don't really make them totally unless the kidney function is disrupted. That's a different thing altogether. So suppose the kidney function is altered, the creatinines are high, he's not passing enough urine, there you can restrict. It would depend a lot on the urine output. So we normally, in a standard steroid sensitive nephrotic syndrome, who you are seeing in the outpatient or with moderate edema in the hospital, I would not restrict fluids. Do we restrict salt in children? I think I did answer this, only till the time of relapse, not thereafter. But it's a good idea to restrict when they have massive edema. How many days of continuous furosemide for additional spironolactone? There is no precise cutoff, Dr. Biswas, but generally we say about more than 2 to I would say more than 3 days. I must tell you, that in the outpatient practice, I don't write more than 2 days of furosemide anyway. I tell the parents that don't give for more than 2 days. If you still need to give, then you need to see the child again, or you give a break for a couple of days and then you can restart furosemide. So be careful using furosemide in for multiple days in outpatient practice. We have seen enough thrombotic episodes happening to be wary about long-term furosemide. Many times you have encountered scenarios when a child is in AKI and has severe edema and hypovolemia. Yeah. So if he is in AKI, if he is not passing any urine, again, Uma, somebody who has severe edema and who is not passing urine, hypovolemia would be odd, unless there is sepsis or some, because to me, a child who's in AKI would not be passing urine unless his outputs are fine. This is a tough question to answer, so I really can't, maybe I'll think about it and get back to you. Yeah, maybe Sumantra can try answering, but overall, somebody who's in AKI, which should not really have hypovolemia, there you would really have a positive fluid balance. And yeah.
Probably she's trying to ask about hypovolemia mediated AKI. The hypovolemia is the reason for the AKI in case of nephrotic.
But once you have AKI, then you would restrict, Yeah, once you have AKI, Uma, you would be careful with fluids. One cannot then, once you have established acute kidney injury with the raised creatinine and so on, and the very low urine output, I would probably manage him carefully, not give too much fluids.
Yes, sir. Yes, sir.
Do we need to
I'll be
restrict?
with caution.
Yeah. Do we need to restrict oral fluid in severe edema with IV volume maintained? If you are giving a lot of diuretics, if you're infusing IV fluids, if you're infusing IV fluids with albumin and there is severe edema, I would be a bit careful about allowing unrestricted fluid intake. It's a good idea to probably restrict fluid intake. On the other hand, as I said, that most children for moderate edema, and unless you're giving IV fluids, unless you're giving IV furosemide, I don't think we need to restrict. I hope I'm answering, coherently in what you want.
Yes, sir.
A role and importance of restriction of fluid intake. I've addressed this. Can we give lacilactone? No. Lacilactone has got a very small dose of furosemide. The important drug is furosemide. Furosemide about 2 milligram per kg. Lacilactone ki problem kya hai? Lacilactone I think has got 10 mg of furosemide, which is essentially. So I very often kids come to us with edema, and I would use furosemide for 2-3 days. If not getting better, add spironolactone, and still not getting better, consider hospitalizing and giving metolazone or whatever. And
20
how many
plus
days
50, 20 of furosemide and 50 of lactone.
Do we ever 20 is too small?
Yes, sir.
Because I would rather not do that. Yeah.
Right, sir. Right, sir.
How many days before IV diuretics? Again, it depends on the severity, Anand, of the edema. If it's a very severe edema, and you think even if you were to give, problem kya ki furosemide, while it's a good drug, its bioavailability is not more than 40-50%. So because of gut edema and so on, other reasons, it may not always be effective. So there you may really want to give IV diuretics even early enough. But I would imagine, so if you get a severe edema who you are hospitalizing, perhaps in about 48 hours, one would be resorting to IV diuretics. Which is better, oral or IV? So as I said, I should have probably shown you a figure. Danish, the thing is, that oral furosemide, the levels rise and the area under the curve is higher than with IV furosemide, because IV, you have a peak and then there is a fall. So the total area under the curve with IV furosemide is not that great. And that's the basis, So if IV furosemide works, suppose in one patient oral has not worked, and now IV works, so you've got two things. You can either give 2 IV boluses a day or 3 IV boluses a day, or you can give an IV bolus followed by an infusion. Because by giving an infusion, then you are able to sustain the levels of furosemide in the blood, and thereby, you are able to get good area under the curves. In oral, one dose is better or divided dose is better. Again, depends on the edema. If the edema is minimal, or suppose it's moderate, very, very minimally moderate or whatever, OD is fine. But if it's more than that, I would probably give twice. Again, give the second dose early in the afternoon. Don't wait till the night. But ask the parents if the child is passing enough urine. The dose has to be right, Danish, because if you were to give a small dose, it's no use, it's not going to cause any effect on diuresis. So 20 OD, then suppose a child is weighing something like 20 kg, I would probably give 40 mg OD. And that's what I would normally do. And ask the parents if 40 OD is working. If she says it's not worked at all, I would probably give 60 OD, rather than trying to give 20 BD or sorry, 40 BD, because if it's not worked, it's not crossing the threshold. I hope I'm clear. Can we prepare 5% with 20%? Yes, we can. I think we can, and very often we have done that. That you add, saline and make it 20%. So the salt ka load बढ़ता, but it doesn't matter. Because that's the only, if you don't have 20%, karna wahi hai. After the edema, and we have ensured normal intravascular volume, yeah, in fact, if the edema has gone away and you really require an antihypertensive magna, then the use of ACE or herb is recommended, chiefly for its multiple benefits. So clearly, that's our first line agent. Is the method of diuretic bolus versus infusion important? Both are important, because infusion, if you start with the infusion, you may not really get the peak, and you may not really cross the threshold for a diuretic effect. So the initial, even if you elect to give an infusion, you would have to give a bolus first. A child who is not responding to a bolus will never respond to an infusion. That's the second point. So, but on the other hand, having worked for so many years in the specialty, children who are so bad, they really require albumin. Don't try to use too much of diuretics alone. They require albumin to be given early enough, avoiding obviously fluid overload. I'm not saying so, because now even if you give the IV infusion or IV boluses, they work for about 48 hours, and then again you're back to the same same place. Particularly in steroid resistant. So I would probably resort to albumin earlier. Another drug, that's been used at times, and Sumantra knows that, has been tolvaptan. It works at a totally different site, And but again, would work in some patients, but should be given under supervision, because hypernatremia is a complication there.
Yes.
How to calculate fluid intake in children? Is it insensible loss plus previous urine output? In a child who has normal kidney function, Subhajit, I would probably give the way I would calculate for a normal child. So the standard holiday Seger formula. Unless there is massive edema, hyponatremia, or AKI, there you would restrict. Hypovolemia mediated AKI. Can we not try a fluid challenge followed by a dose of diuretic? Hypovolemia mediated AKI. Can we not try a fluid challenge? Yeah, absolutely. It again depends on how bad the AKI is. Now imagine, Narayan, a patient coming to you with a creatinine level of 4 versus somebody coming to you with a creatinine level of 1.2. Clearly, it's 1.2. You can try giving a fluid challenge and followed by a dose of diuretic. Give a fluid challenge. Maybe you require 2 fluid challenges. But suppose किसी का creatinine 4 है, and previously it was something like 1 or 1.5, or say, sorry, 0.6. So then it's too far out. Then you have to be careful. So I think it depends on the severity of the acute kidney injury, severity. If he's totally anuric for, say, 3 days before coming to you, and there is the creatinine level is 3, clearly it's a bit too late. How to manage asymptomatic hyponatremia? Just restrict fluids. Unless the sodium is really low, there you can probably give some 3% if you're really worried about a seizure or whatever. How many days after starting prednisone diuresis starts? Sensitive nephrotic syndrome, it begins normally by the end of first week, maybe even earlier. In fact, diuresis begins even before the albumin becomes negative. So diuresis would precede remission, and so it would begin early enough. But if there is more than modest, if there is moderate edema, there is no harm giving 2 days of diuretics. And the way I define moderate, but then not more than 2 days. Should we start aeratus long with steroids? Should we start after some days of steroids? Severe edema with intravascular volume maintained. Uh, somebody who comes with severe edema, and I'm, yeah, uh, somebody who has got massive edema, anasarca, I'm more worried about reducing the edema. I would probably use steroids after some edema is less, because hoga kya? If you start 2 milligram per kg, they're going to retain even more fluid. So very often, you tend to avoid giving them very high dose steroids in somebody who's already admitted for severe edema in the hospital. Don't confuse this with somebody you're managing in the outpatient practice, but somebody who's got massive edema, anasarca, ascites, pleural effusion, steroids can wait, just reduce the edema, get him better, and then start steroids a bit later, maybe 3-4 days later. Below what level of albumin should we infuse albumin? Tough to say, Manisha. There is some data that levels below 1.8 are clearly not going to get better, So one should be, so anything below 2. And do keep in mind, what we call as 2 is below 1.5. Because as I said, in our whole country, we do bromocresol green. We don't do the bromocresol purple. So with the guidelines that you read from international literature are higher albumins than ours. Our albumins are perhaps, we are over reporting albumins. But clearly somebody who has got, again, Dr. Manisha, somebody who has severe edema, but the moderate edema में normally हम नहीं दे रहे होते albumin, unless तुम्हें डर है कि he comes with cold clammy extremities, and you're worried that he may go into kind of thrombosis or whatever. Again, you have to decide based on the volume, status. If he's hypovolemic, then just use albumin alone. If he's edematous chiefly, then use albumin with furosemide. Okay, thank you very much. Jagisha is the last question. In case of infection, child is in relapse. Agar severe infection is Jagisha, I would probably just manage the infection first, If he has been on corticosteroids in the last 1 year, then probably, give this stress dose of corticosteroids. But let the infection subside, and then you suppose it's peritonitis. I'm just mentioning peritonitis or pneumonia or something of that sort, But I can answer this later. So I hope it's too many questions,
Thank you, sir, for this extended long session and clearing all the doubts. Sir, actually,
sir, we can take a few questions more.
Yes, sir. Our residents have some questions, sir. One more ward-based questions. Suppose a 20-kilo child with nephrotic with severe edema admitted in our ward. No signs of hypovolemia. This is a more practical based questions which we are facing currently in our ward. So the normal otherwise for a 20-kilo child who is currently 25 kilo because 5 kilo of overweight, but no hypovolemia. Otherwise, we should have given him 1500 ml of intake for a 20-kilo child, oral or IV. So the child is passing probably 200 or 300 ml of urine only per day because of this nephrotic state. So currently our current pattern for 1 day or coming 2 days will be giving 150 ml same fluid and giving albumin analysis to make a 2200 ml of urine output. So that's why we can decrease the weight 500 or 700 gram per day, or the reverse. We restrict the fluid up to around 500 ml and give albumin analysis and make a urine output of target around 1000 or 1100. So that's why the same weight gain, the same weight loss, that is 500 to 700 loss per day. In both the situations, same weight loss we are achieving, but in first case, say normal intake, but a excessive high output versus the second day restricted intake and a reasonably achievable urine output. Which of the two?
There are no clear answers to everything. Medicine is not that simple. But the only I would probably still say, that normally you don't restrict unless the 2 or 3 situations that I mentioned. If there is clearly reduced output with a high creatinine, there is hyponatremia, or
the third one is severe edema, sir.
Yeah, if there is severe edema and you're requiring the use of albumin to reduce the edema,
Yes.
Right. Normally, itna farak padta nahi hai on the child, as long as you are careful. But I agree with you that whenever we are using albumin or whenever we are using all this stuff, somebody who's oliguric, just be careful. Kids can go into overdose. Kids can go into overdose. I think it's very tough to have very, very clear-cut policies, and that's the reason why even when you read guidelines, the policies are not that cast in stone, and one does have to kind of have it.
It should be individualized case to case.
And one does not know how bad the kidney is, because suppose somebody has oliguria. Now to say for sure that this is an acute kidney injury versus this is just nephrotic state, you can only determine, in the next 1 day. So I think one has to be cautious. So I would not try to make too many rules. I think it's not good to probably.
Right, sir. And
Sumanta,
wherever
we
our
can
Lasix
ask
has
few
a,
more question. We can
yes, sir,
ask few
definitely,
more
definitely,
question.
definitely,
Is
sir.
there any role of renal dose of dopamine to increase urine output in NS? Manveer Singh, sir. He has asked you this question.
So Manbir, I no, we do not. We do not think so. देखो तुम्हें वैसे ही Manbir, I'm sure you're aware that the overall, when you look at large studies, large randomized trials in adults chiefly, very few in children, dopamine has really gone off, as a agent to prevent or to treat acute kidney injury. So most pediatric units, most pediatric nephrologists would not be advising this. It doesn't have any benefit, so we do not. So answer is simple, is clearly no.
Sir,
Uh,
another question. Child is in relapse, but present with complaints of diffuse abdominal pain, no tenderness, USG normal, counts normal. What else to think of, sir?
So if there's a relapse with diffuse abdominal pain, and if there is, so obviously pain with the relapse, the first thing I would always think of is hypovolemia, and so keep that in mind. And Sumantra knows that, so it's hypovolemia is the first thing. Obviously, then the other things are peritonitis, gastritis, corticosteroid therapy, pancreatitis. But as you said, the ultrasound is totally normal, So I would probably be I would be thinking that it's probably the relapse. If there is a ascites and the child has got a lot of pain, I think we should be doing a tap. It's something that can be done easily, and we end up doing it. But but clearly, hypovolemia is a much more important feature of the cause than peritonitis per se. But the first two things are really these two, and thrombosis वगैरह uncommon होता है, causing a lot of pain abdomen. Thrombosis would have other features as well.
So the last question, role of stress dose of steroid in SSNS with relapse associated with infection. Is that helpful?
Yeah, Prithviraj, try to, there's been some controversy on this over the last few years. So one is, giving stress dose of steroids. So you're saying role of stress dose of steroids. So I think you mean that a child who has steroid sensitive
Infection,
nephrotic
yes.
syndrome, who comes with peritonitis, and he has a relapse. How do you manage? I'll address all the possible things. So sensitive nephrotic syndrome, peritonitis, or bad pneumonia, who has a relapse. I would treat the relapse. I would treat the infection with the appropriate antibiotics. If he has got steroids in the last 1 year, I would give him something like 0.5 to 0.75 milligram per kg of prednisone every day during the period of stress. This is one part of it. You have a SSNS with the upper respiratory tract infection with a relapse. I would manage the relapse in the standard way, with corticosteroids. This is a relapse now. So SSNS who has now edema with a URTI, you can treat the URTI, with the whatever you want to treat it with, but you can start steroids simultaneously. The third situation is, what's been the issue of controversy is that suppose you have a child with steroid sensitive nephrotic syndrome who gets an infection. We know that infections can precipitate relapses. Is there a role of giving daily steroids to these children to prevent a relapse? Okay, so wahan pe that data is still a bit ambiguous. There was data from our country that said that giving something like 0.5 milligram per kg for 5 days prevents infection-induced relapse. But the most recent study from UK, the Prednos trial, did show that perhaps it's not as effective. So the current IPNA guidelines would say is that in children who have multiple infection-associated relapses, so and here infection means upper respiratory tract infection or fever. So in children who have got multiple infection-associated relapses, it may be a good idea to give 0.5 milligram per kg per day for up to 5 days to prevent a relapse. So I've told you all the three situations, but once you have a relapse, then he has to be managed in most appropriately with the standard therapy. Okay, I hope I've answered what you asked you.
Thank you so much, sir. Thank you so
Sir,
much,
last
sir,
one. Sir,
for
why not we are
answering
using
all the
torsemide as a
questions.
usual one? Because
Sorry?
Lasix is a 20 to 30% of absorption, that is a variable, whereas torsemide
Yeah.
has a 80% viability
I don't
on a more
Trasimide,
non-variable
yeah.
one.
Yeah.
And adults are using it left and right. Why not in pediatric nephrology?
Data nahi hai, isliye nahi kar rahe, and we have got more
That's why.
experience.
Okay.
That's the only reason. The only reason why we don't use furosemide is not because of its lack of efficacy. We don't have that much data. I think we require
Evidence.
some good studies to show
Okay,
that.
sir.
And I think given this current, so furosemide, you've got years of experience. That's
Right.
the only reason. But I agree with you, Sumantra. Yeah.
Thank you. Thank you, sir. Thank you very much, sir,
Thank
from
you
our
so much,
core of
sir.
heart. Thank you, sir.
Okay, thank you, Sumantra. Thank you for the opportunity to talk to all of you.
Thank you, sir. We learned a lot.
Yes, very much gratitude to you because you patiently, I think, answered all the questions. So just unimaginable. So
35 minutes
thank
of
you, sir.
QA only. The question answer was only 35 minutes. It's more than the talk itself. Thank you, sir. Thanks you once again. So now onwards, can we?
Thank you, everybody. Yeah.
Okay, sir. Good. So can we request Swapun sir to call our next speaker on dais? Next hour is Dr.
Our next speaker is Dr. Ognishekar Saha. Dr. Ognishekar Saha. Actually, Sumantra.
I hope what he will be talking. Just name the subject. What he is going to talk.
Yeah. Actually, Sumantra is the coordinator. You
Okay,
must
Sumantra,
introduce-
you do it. We do
Sir.
it. No issue.
Now
okay,
you
sir.
will be
Thank you.
coordinating and introduce Dr. Ognishekar Saha.
Okay, sir. No problem. So our next speaker will be the great and vibrant Dr. Ognishekar Saha. Dr. Saha is an MD and MSc and he is currently the consultant in pediatric ICU at Apollo Multispecialty Hospital. And sir has multiple achievements in his own pockets. So now I welcome Saha sir to show his PowerPoint. So Dr. Ognishekar, can I stop my screen sharing and you can start your slides? Is it okay? Dr. Agni, are you audible?
Do you want me to share screen from my end, or you
Yeah.
are okay
Right.
with?
No. I'm stopping my screen sharing. You just do from your end. Is it okay?
Yeah,
Okay.
I think so.
Fine. Please do, sir. Please do.
Right. Let me just.
Our audience are again requested to, if they have any questions or any queries, they can put it in the chat box. Better not to put in the QA. Put in the chat box. Whichever we are able to answer live, it will be answered. Otherwise, we can answer it writing in the chat box or in the WhatsApp group, which is for the attendees. Okay.
Sumantra, I saw
Yes,
many attendees that they have not written their name. Some XXY
Yeah,
something.
right.
Ask them to write the name so that they can get some recognition in future. If you plan to give some certificate of participation, it will be difficult for us to give them.
Yeah. Attendees are requested to ideally log in with their name because it will be helpful for our day 3 quiz session also. So please log in with your own names. Thank you. So over to Ognishekar sir.
Am I audible?
Now little bit problem. Mirza sunte pacho?
Bit louder, Ognita, bit louder.
Am I audible now?
We can switch off the video also if any net connection is problematic. If it is required at all.
Am I audible now?
Yes,
You are audible
now.
and visible. Your slides are also visible and moving. Please continue.
Thank you to the organizers for having me. And I had a lot of technical glitches which I just didn't imagine will happen. So yeah, much further ado, let's start.
Beat vibration, beat echoing probably. Are you using some device? Yeah, or
Going Ognita and sound is
Can you
breaking.
suggest something?
What's wrong?
Now it is okay. I think you have to be a bit closer to your system.
Right. Is it better? Is it better?
Yes, now it is audible. Yes.
Right. Okay. So the topic is the basic physiology. First thing first, we'll of course, as the topic says, we'll cover the relevant physiologic principles, and because they are a bit unrelated, so the talk may sound a bit disjointed. A lot of it is already known to most of you. So please bear with me if you find it a bit monotonous or boring. But at the same time, we'll try to cover, or may I say even uncover, bits that are usually not there in the books. And we'll focus on the stuff that we actually do rather than very detailed theory. Now, body fluid means basically water, okay? And 60% of our body weight is about is water, right? Now, out of this 60%, 2/3, that is 40% is inside our cell. So that is called intracellular fluid. And the rest, that is 20% of the 60%, is outside the cell, that is called extracellular. Now, this extracellular fluid, 20% of it is within our vessels, that is 4% of the total body weight, and rest 80% is outside our vessels, right? So we have only about 20% of our extracellular fluid is intravascular, and we have only access to that. Remember, we do not have access to any intracellular fluid. We do not have access to any extravascular fluid. Now, that would not matter if the composition of both the extracellular and intracellular fluid were equal, but that is hardly so. As you can see from this table, but the compositions vary markedly, right? Say for sodium, it is 142 outside the cell, and inside the cell only 10. Calcium outside 2.4. Intracellular calcium means cell death, so inside hardly anything. On the other hand, take potassium, outside only 4 milliequivalent, inside 140. Magnesium, outside only 1.2, inside 58, right? Similarly, for negative charge ions, chloride, outside 103, inside 4. Big difference. Again, phosphate, the reverse, outside only 4, inside 70, right? So the point is that the ionic concentration between the extracellular and intracellular fluid vary markedly, and it has got certain consequences to how we manage fluids. This is something quite unusual in nature. This is very and you know, we spend a lot of energy just to maintain this concentration gradient. A lot of our BMR is spent just to do this, but this is how it is in all living cells, including plant cells. So how do we manage fluid? How much fluid does a kid need? We have this very common 150 and 20 rule that we use every day. So say a 23 kilo kid. So for the first 10 will be 100 per kilo. So that will be 1 liter. For the next 10, it will be 50 per kilo. So that will be another 500. And then if it is 3 kilo left, for that 3 into 20, that is 60. So 1560. We all do it every day. And our sodium maintenance requirement is thought to be 2 to 3 milliequivalent. Potassium is 1:1 to 2. This is written everywhere. Now, why do we think so? Where from does this come? This comes for the holiday figure, as again, most of us know. Look at the year of publication, 1957. Very, 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 very old, right? And this is a great paper, of course. It has, established the foundation of fluid electrolyte calculations, but it has got issues. We do not have the time to go into the details of it. We will not do that. But basically, if you look into close to it, Halidasegar did not do any original work. What they did is they have picked up from works that were already done at that time or even before them. And they have synthesized those works to figure out what could be the fluid and electrolyte need for an individual, right? And there they have taken two, for how do we lose fluid, either through urine or through insensible loss or sweat, right? And they have used the data that were already prevalent, already done there. As for example, for insensible loss, he has this 930 ml per meter square per day or 750, which were done by works at 1955 and 1931. But we know that is not true. Nowadays, for insensible loss, we use much less, 450 ml per meter square per day. So basically what they have done is they have grossly overestimated our fluid intake, the Halidasegar. So the 150-20 actually overestimates our fluid intake. Let's bring in another factor, that is SiADH, ADH secreted from posterior pituitary. What are the causes for SiADH? Non-osmotic causes, say CNS, infection, tumor, trauma, pulmonary infection, asthma, ventilation. Then C, nausea, vomiting, pain, stress, post-operative, medications, NSAIDs, morphine. Says C, point C, can you think of a single patient who is admitted in a ward who does not have either nausea, vomiting, pain, or stress? Hardly. So NSAID, so SIADH is extremely common, especially in inpatients. And if you have a SIADH, then your fluid requirement goes even further down, right? So nowadays, the general consensus is that the 150-20 formula actually overestimate our fluid need. And we all possibly intuitively know it. Why do I think it? Because, just think how easily we say, let us restrict fluid to 2/3 maintenance. We say that just like that. Do we ever say, let us restrict antibiotic to 2/3? Do we ever say, let us restrict analgesia to 2/3? Do we ever say, let us restrict our antihypertensive to 2/3? We don't do that. We don't even think like that. But we restrict fluid just like that. So possibly we all intuitively know that we are overestimating our fluid need. And how about sodium? What Holiday Seger did? They themselves said that less precise data are available and figures considerably in excess of the minimum requirement are readily handled for sodium. And basically this 2 to 3 milliequivalent per kilo comes from the normal intake of a newborn who is on formula feeds of 150 ml per kilo per day. That's the thing. That's all the evidence they have. So this 2 to 3 milliequivalent per kilo per day comes only from a newborn who is on a formula feed and who is on 150 ml per kilo per day. So this maintenance requirement of 2 to 3 is again a myth. So the take-home message is that the maintenance fluid should never be 1/5 DNS, which is still practiced somewhere. This is basically based on Holiday Seger, and that is wrong. For maintenance fluid, please do not use anything which is less concentrated than half DNS, at least half NS, I mean. At least half NS. If you are using anything more diluted than that, then you'll be ending up with bad hyponatremia. Now, when we are, but this is when you are inside a hospital, inside a ward. But when you are not there, when you are sort of our day-to-day activity, we do not do any measurement. We just take as much solid, as much salt, as much fluid as we need, and still our serum sodium remains within a very narrow range. Our potassium remains within a very narrow range. How does that happen? Because you have got kidney, which is such a wonderful organ, right? Remember that our urine osmolality can range anything between 75 to 1200 milliosmol. That is a factor of 16. So a solid load that can be excreted in as small a volume of 100 ml can also be excreted through 1.6 liters, 16 times. So even if you have taken 100 ml water or you have taken 1.6 liter water, you will still be okay. That much space it has. And also in terms of solid salt intake, you can take 1 gram salt a day, and the other day you can take 16 gram of salt. And even if you take the same amount of water, your sodium will be still okay. So kidney is a fantastic organ, and that is why we can maintain all this without really measuring how much we are taking and what we are taking, right? So if your kidney is working well, you have to be really bad to end up with a dyselectrolytemia. However, if your sodium is not working, then this is the golden rule. Replace urine output plus insensible loss. This is the golden rule for fluid and electrolyte. If you follow this, you can never go wrong. Now, a few words. I'm not maintaining time. I don't know how much time I have. So yeah, let's talk a little bit about isotonic, hypotonic, and free water. So what is the difference between tonicity and molarity or osmolarity, right? Osmolarity basically tells you about how many osmotically active particles are there in a solution. So basically, what is the concentration of the different solutes? That is what osmolarity tells, right? But what is tonicity? The very concept of tonicity does not come unless you have a semi-permeable membrane. The concept of tonicity comes only when you have a semi-permeable membrane. And if you have a semi-permeable membrane, which is our cell membrane for biology, then the tonicity, only those particles which are not freely movable, which freely moves across the membrane, they will not contribute to the tonicity, although they will contribute to the osmolarity, right? And particles that do not freely pass through the membrane, they will only contribute to tonicity. For biology or for medicine, for all practical purpose, 5% dextrose or dextrose is the molecule that can pass freely through a semi-permeable membrane. So dextrose will never contribute to tonicity, although it will contribute to osmolarity, right? And all the other electrolytes, they will contribute to both osmolarity and tonicity, right? So what is an iso? So let us just have a look at this table. 5% dextrose. So as we have understood that dextrose contributes to osmolarity, but not tonicity. And if it is 5%, then that is isoosmolar, right? So 5% dextrose by definition is isoosmolar. What will be its tonicity? 0, because it contains only dextrose. 2.5%, which is less than 5%, so it will be hypoosmolar. Tonicity again 0, because it only contains dextrose. 25% will be hyperosmolar because it is more than 5%. Tonicity again 0 because only dextrose. 1/5 DNS, which is 5% dextrose with 0.18% saline. What will be its osmolarity? If it is just 5%, it will be isoosmolar. On top of that, it has also got some saline. So its osmolarity will be more than isoosmolar. So it will be hyperosmolar. But what about its tonicity? Its tonicity will not be 0 because it contains some sodium. But remember, 0.9% is isoosmolar. It contains less than 0.9% saline. So it will be hypotonic, right? Half DNS, which is often used, 5% dextrose with 0.45. Again, because it has got something more than 5%, so 5% dextrose plus some saline, so it will be hyperosmolar, but its saline content is less than 0.9, so it will be hypotonic, right? DNS, 5% saline with 0.9%. Again, 5% plus sodium, so it will be hyperosmolar. But because it has got 9% saline, so it will be also isotonic. Normal saline, by definition, if it is 0.9% saline, that is isotonic, and that is also isoosmolar. On the other hand, say half NS, 0.45% normal saline. It has got no dextrose, only saline. So the sodium only contributes to both the osmolarity and the tonicity, and it is less than 0.9. So it will be also hypoosmolar as well as hypotonic. 3% saline will be both hyperosmolar and hypotonic, right? So that is how, so isotonic, to be isotonic, you have to have at least 0.9% saline. Dextrose will not contribute. So that is how it works.
8 minutes more.
8 minutes more? Okay.
Yeah.
So let's just do this. So what happens during hyponatremia? If you've got your sodium outside the cell is higher, so what happens? Water comes out of the cells. So your cells shrink, right? So your brain also shrinks, right? As the brain shrinks, so those cells, they want to sort of draw water from outside. So they generate some osmotically active stuff within the cell, right? Which are called idiogenic osmoles. And they then subsequently draw some water from outside so that the cell shrinkage gets better. And this happens over a period of about 48 hours. Now, once that it has happened, the cell shrinkage somewhat compensates. Now, when you are correcting it, so when you are correcting the hyponatremia, so now what is happening? The sodium concentration outside the cell is getting low, right? But remember, the osmoles that are within the cell, they are still there. They do not disappear. So if you're correcting it too fast, then what will happen? The osmolarity outside the cell will drop too fast, but the internal osmoles will remain active. So they will draw water. They will keep drawing water. So your cells will swell. Now, if your cells swell in any other area of the body, you are fine, but not if your brain swells. Why? Because the brain is enclosed in a closed box, our cranium, which cannot expand. So that is the problem with hypernatremia, with correction of hypernatremia. If your hypernatremia is too fast, then you can end up with cerebral edema, which can kill you, right? So the rate of fall should never be more than 0.5 millimole per hour, or in a day about 12. Some people are suggesting that it should be even less than that, somewhere around 8. And what happens during hyponatremia? Well, if you have got, so the reverse occurs. So the sodium content outside your cell is low. So the osmolarity outside your cell is low. So water enters into the cell. So your cells swell. As we have already said, if your cell swells, everywhere we are okay except your brain. So when you are having hyponatremia, the hyponatremia itself can cause cerebral edema, which is the primary concern about hyponatremia, right? Now, as it happens, but then as you correct the hyponatremia, if the hyponatremia is long-standing, and then as you correct it, there will be some shrinkage of the brain, right? And as a result of it, the exact mechanism is not quite known, but you can have what is called, nowadays it is called osmotic demyelination syndrome, ODS, what we previously used to call central pontine myelinolysis. And that is, the exact mechanism is still not clear, but it is something devastating. You can have, quadriparesis, you can have locked-in syndrome, you can have something quite like bulbar palsy, and it happens about 4 to 6 days later, and it is a devastating thing. So here again, when you are correcting hyponatremia, what is most important is do not correct it too fast. Here again, the rate is, classically it has been said 0.5 per liter, 0.5 per hour or 12 per day. And again, some people are saying maybe that too is risky. So it should be less than 8. That is why we should do it a bit slowly. Just a small break. Let's move this. So this is the last topic is, how when we have got a hyponatremia and we need to replace the sodium. We need to give sodium. Some much sodium is low. So how much sodium do we use and what formula do we use? So what is your total body water? Your total body water is body water into 0.6, yeah, because 60% of your body is water. So that is your total body water. So if your sodium concentration is 140 milliequivalent per liter, then what is your total body sodium? Body water into 0.6, which is your total body water. Body weight into 0.6, total body water into 140, because it is, you want your sodium concentration to be 140 milliequivalent per liter. And say we have got your current sodium is less than that. So what is your current total body sodium? Body water into 0.6 into current serum sodium, right? So how much, what is the deficit? The difference between two. So body water into 0.6 into 140 minus your current serum sodium, right? That's the logic. So suppose you have got a 16 kilocalorie and my serum sodium is 115 and my normal sodium is 140. So you have got a deficit of 25. So what will be your sodium deficit? So 25 into 16, which is 400, and then 400 into 0.6. So that is about 240. Of course, we will not do it in 2 days because 25 is too much. So we'll possibly do it over 2 days. So that's about, so 120 milliequivalent sodium to be corrected in 12 hours. And we will use it by 3%. 3%, each ml of it contains 0.5. So the volume of 3% needed will be 120 into 2, that is 240 ml. right? Everybody is happy with that formula, right? Now, what are the pitfalls? So what has been the drop in sodium? The drop in sodium is 140 minus 115, that is 25. Your sodium has dropped by 25, right? Now, look at this table. You have already seen it. What is the sodium concentration inside the cell? 10. If the sodium concentration itself is 10, can it ever drop by 15? If it drops by 15, then what is the sodium concentration inside the cell? -5. Does it make any sense? Yes. So it does not make any sense, right? So this is a big pitfall. And what about the output? Sorry, we are thinking it is like when you are doing the formula, we are taking it like a one chamber static model. But that is not the case. We are continuously passing out urine, and the urine contains variable amount of sodium. We are not taking consideration of that either. So these formulas are absolutely very basic bad guesstimates. And remember, in adult, they have stopped using this formula. But we have to do this because our size of the kit varies. Our size of the kit can be anything from 6 kilo to 66 kilo. So you have to have something to start. So these formulas are not set in stone. These formulas are very rough guesstimates. So what actually keeps us? How do we still survive? We still survive only because we keep monitoring. So these formulas gives you only the starting point. And once you do that, please keep monitoring what is the sodium doing, and then change your stack, you have to change your concentration, you have to change your volume. So you need to keep changing. Monitoring is the key, not the formula. These formulas are pretty base and not really that good. People have stopped using. So be humble. Thank you. Any questions?
There are a lot of questions. It's an excellent presentation as usual, but there are a lot of questions. So we'll go one by one.
Sure.
Okay.
Shall I stop sharing?
Let it be there. No problem. So I'm starting from the back. Infants less than 6 months, what would be the ideal maintenance rate?
Right. One thing, my entire topic did not cover neonates. For neonates, I think it's still 1/5. The reason is the neonatal kidney cannot handle sodium as good, right? So for neonate, it is definitely 1/5. For a 1 kilo, I will say it has definitely around half DNS at least, or maybe even DNS, depending on the physiology. For a 6 month, it will be somewhere in between. I will start with half DNS, but I will be prepared to cut down.
Okay. So is there any use of Isolite P in children as maintenance fluid? That a Krishna Borgohan.
Thank you for asking that question. I've already highlighted that, and I would like to say it again. There is no place of 1/5 DNS, Isolite P. And there are many others with a P suffix in it, and the P stands for pediatric. They have no role. They have been banned. In UK, if you want it, then you have to speak to the pharmacy and you have to actually explain why you want it. Unless you are in a PIC, you can just use it. So for all practical purpose, no. Remember, I am excluding neonates from this discussion. For neonates, yes, there is a role.
In older children, do we use Isolite P versus 10% or 5% dextrose in neonate as maintenance fluid?
What is the question, Chapanda? Say again.
Yes, sir. Why in older child we use Isolite P versus 10% to 5% in neonate as maintenance fluid? It means in neonate we use 10% in the first 2 days, and then we use the 5% dextrose containing fluid. Why in older children, why do we use Isolite P? I think you have answered already.
Again, we do not use Isolite P. If you are using Isolite P, please, if there is one take-home message from this talk, stop using Isolite P, please.
Okay. So Other questions? What is
And the
recent
reason for
guideline?
isolate, not why isolate P is so bad, I think that has to be sort of mentioned, because that can lead to significant hyponatremia. Hyponatremia can cause cerebral edema and it can kill you. And there has been many cases where it is well documented.
Dr.
Yeah.
Gitanjali has asked the same question. What is the recent guideline on use of the isolate in hospitalized children? Already you have given answer. So we are taking the last question. Any specific fluid for the post-operative patient in pediatrics?
Yeah, post-operative patient. Good question. I'm in a post-op patient. They will be in pain. Post-op is again a sort of very high stimulus for SIADH, right? So they can develop SIADH, and if they develop SIADH, their sodium can drop. And again, the whole this thing of changing the maintenance fluid from anything hypotonic to isotonic actually came from a case series where gynae patients, actually adult female patients who had very simple surgery, something like abortion, and they had these hypotonic fluids and they ended up dying. So that is how it all started. So if it is a post-op patient, is the noise somewhere.
Yeah, upon Dr. Datta, Kalpana Datta.
Yeah. Okay. So if it is a post-op patient, all the more reason I will use even normal saline. Maybe if you be a small kid, you need some dextrose, so I will use DNS rather than half.
Dr.
And
Ogni,
the
just stop
hypotensive
sharing.
component.
You just stop sharing slides.
I should stop sharing. Yeah.
Yes.
In fact, I have requested Ogni to.
And there are many questions in the
last
chat
question.
box. So,
Last
doctor, many
question.
questions in chat box. You see
Yeah,
the
ask. So, sir, is there any indication of using KCl routinely with the half DNS?
Absolutely. You should always use KCl. I mean, potassium is very important. And we all have a maintenance need of potassium. So yes, if your kid is going to be on IV fluid for something like a day, then it may not matter that much. If your kid is going to be on IV fluid for a prolonged period, anything more than 24 hours, I will always add potassium. Definitely. Otherwise, you will end up with hypokalemia.
Now, Dr. Narayan Santuka has opened the Pandora's box. How reliable are the electrolyte values in ABG? How do we ensure that we get as close to accurate ABG electrolyte values? So,
that depends on how good your machine is, basically. And the machine needs to be maintained properly. The machine needs to be calibrated properly. If it is calibrated properly, then oftentimes they are pretty good, actually. But then, and how will you know they are pretty good or not? Is you will have to regularly do samples on both. You do a blood gas, and at the same time you send a lab and see how are they tallying. If they're tallying fine, then I am absolutely okay with that. And if it is not tallying, then speak to the speak to your biomed people or speak to the company who is providing it and tell them why it is not doing it. Because ideally it should come pretty close. If it is not, then there is something wrong in the calibration. It should be sorted out, and the company people can do it.
Dr. Akanksha Titya has asked, sir, is there any specific indication or contraindications for adding MVI in IV fluids?
MVI in IV fluids. Yeah, they're pretty. I mean, if again, it depends on what sort of patient you are having, whether your patient is having some enteral intake or not. If your patient is having some enteral intake, then he may well have this stuff from enteral. If not, if your patient is entirely on IV fluids, then I think it's worthwhile to give MVI. The thing also important is, if your patient is going to be entirely on IV fluids for more than something like 70 to 96 hours, then you should also think about providing some nutrition. You all should also start thinking about some sort of parenteral nutrition.
What is the contraindications of giving MVI? What is the contraindication of giving MVI in IV?
Contraindication of MVI?
Yes,
I'm not aware of it.
Okay. How much sodium correction can be done per day? Divya.
I've already answered that. Look, the classical teaching has been 0.5 per hour or 12 milliequivalent per day. However, currently, people are saying that even that may be too much, and you may cut it down to even something like 8 to 10. So people are trying to be even more conservative recently.
Under 1 month, we use the Isolite P fluids. After 1 month, what fluid do we use? Half DNS or DNS?
Definitely not DNS. Look, the change is obviously gradual. The problem is that the neonatal kidney cannot handle the sodium well, and then the capacity gradually develops. It does not develop overnight. It is not like a switch on, switch off phenomena. So yes, neonate first 4 weeks, 1/5, and then I will say around 7-8 months half DNS. In between, it is somewhere in between. What I will do is I will start with half. And then if my sodium is really creeping up, then I will cut it down. It is definitely not a normal saline. It will be less than that.
Sir, if sodium is 110, then should it be corrected over 48 hours, or else it will cross 0.5 millimole per hour?
Yeah, you do not correct more than 12 a day. So yes, unless, look, if you're hyponatremic, then the question is, you are hyponatremic, are you symptomatic or not? If you're symptomatic, if you're comatose, and especially if you are seizing, if you're having convulsion, then you need to correct it quite sort of fast, at least about by 3 to 5 millimole per liter. So you do that. But beyond that, you should not go more than 12. Saying that, real life is not like that. As I've said, these formulas almost never sort of function properly. So you think you don't want to do that. Oftentimes you end up doing that.
Sir, I think we have a separate section on
Yes.
sodium dyslipidemia on
Yes.
day 3 also.
So I think we should stop, and if any question are not answered in the next session, you can put it on the WhatsApp. So next we'll the next session. So over to you, Sumantra.
Okay, sir. Thank you, sir. Thank you, Mr. sir and Sapun sir, and a nice presentation overall and an eye-opening one. So now come with progression of our today's day 1 program forwards. I welcome our next speaker is Dr. Rohit Bhaumik. Dr. Rohit Bhaumik, just a minute. So next topic from our Dr. Rohit sir is, yes, yeah, here we go. Sorry for the technical glitches. So I hope my slides are visible here. So Dr. Rohit is an MD in pediatrics and DM. He has completed his DM degree in pediatric critical care from JIPMA. He is currently working as an assistant professor in pediatrics at AIMS Kalyani, and his most area of interest is regarding critical care nephrology and also critical care. So with this much of thing, I hand over my stage to Dr. Rohit for his wonderful presentations today on different type of fluids in day-to-day world. So I'm stopping my screen, and Dr. Rohit, please carry over forward. Thank you.
Thank you, Dr. Shumantro, for this nice introduction. Hope my audio is fine, sir.
Yes.
And my slides also.
Yes. You're visible, but make it in perfect.
Yeah. So at the onset, I'd like to thank West Bengal Academy of Pediatrics for giving me this platform to discuss one of the very, very important topic, and that is very close to my heart. And we also say my sincere thanks to Professor Kalpana Datta ma'am, Professor Sapun sir, and Dr. Indranil Chaudhary, Professor Mihi sir, and other respected teachers and seniors. As my lecture was followed by 2 extraordinary talks by one of the greatest speakers in India, they have made my job very easy. So the next 20 minutes or more, I will discuss some basics on different composition of IV fluids, and we will go through the indications and few contraindications. So before starting, do we use IV fluids? Whoever is presenting here, starting from interns to even the senior most faculties, may sometimes write it, and it is our day-to-day practice. We use IV fluids. Remember that it is not a simple to prescribe IV fluid. Whenever you are writing, you have to consider that it is a drug. So it has to be handled like a drug, like it has to be prescribed in a proper manner. Dose, delivery, how long to be given, all has to be properly checked and given accordingly, the case-to-case basis. So next few minutes, we'll discuss the commonly used IV fluids, basic composition, and how to remember it in a simple manner. Though, as in pediatrics, we should not always write based on our memory. It is better to check the drug dosage book as well as the composition of different drugs as well as IV fluids too. We will discuss a few slides on preparation of IV fluids that may require in emergency situations. Though ideally, we should give or prescribe the fluids which are customized and readily available rather than mixing in a ward or in emergency situations. Contraindications, already we have discussed few of the contraindications of IV fluids like half normal saline. Agnisar has just now discussed that the importance of not giving hypotonic fluids. Also, Professor Baggas had discussed the contraindications of albumin. What we won't discuss in this is fluid in specific situations, which will be dealt in next 2 days in different talks. What fluid we use day to day? Normal saline, dextrose normal saline, or commonly known as DNS. Very rarely N by 2 5% dextrose, as Sarah said, 10% dextrose if you have hypoglycemia and you are managing hypoglycemia. And nowadays, balanced salt solution is coming in a great number. So Plasmalite, one of the commonly used balanced salt solution, and in newborn, Isolite P. Whenever we see the IV fluid prescription or IV fluid drug dose or in the bottles or in the bags, these are abbreviations you may see. So the abbreviations is whenever D is there, it stands for dextrose. If you have W or WS, it is for only W if it is for water, S for saline, NS for normal saline, and RL or linger lactate for abbreviation for RL. Before going to each commonly used IV fluids, we must know that fluids are two types, crystalloids and colloids. And the basic difference of these two is crystalloids stay for a shorter duration in the intravascular volume because of semi-permeable vascular compartment. After some time, it shifts into the interstitial volume. On the other hand, colloids stay for a longer duration. So in next few slides, we will discuss that what is the basic difference between two. So in day-to-day practice, we commonly prescribe crystalloids. For easy memory purpose or easy recall purpose, we'll go in the order of dextrose to ISOP or Plasmalite. So whenever you have this percentage number, if you see this percentage, that means out of 100, something is there out of 100. So for 10% dextrose, what is it? 10 gram of dextrose in 100 ml of water. In 100 ml, we have 10. So for percentage, especially for the new residents, this is important to understand that it is whenever you have percentage, it is in something in 100. So in 100 ml, we have 10 gram. That means in 1 liter, you have 100 gram. So for percentage, it is for 100 ml. No other electrolytes is there in 10% dextrose. So it is 10 gram in 100 ml, pH approximately 4 to 5, and it is hyperosmolar. You have already understood the difference between hyperosmolar, hypoosmolar, and tonicity. Next come our another common item. It is normal saline or NS. For easy understanding or easy recall purpose, we have to remember it as a 0.9% normal saline. That means again in 100 ml we have sodium chloride of 0.9 gram. In 100 ml, 0.9 gram, that is 0.9%. How much sodium and chloride is there? Easy to remember. It is 154 or 150 in some companies. So 154 of sodium millimole or milliequivalent per liter. It is in liter. So 154 per milliequivalent per liter of sodium and chloride. Nothing else is in there. So in 10% dextrose, it is purely glucose. It is in normal saline, it is only sodium and chloride. Its osmolarity is almost 308 and it is almost isotonic to our body or our plasma. Next, we go to 5% dextrose. So easy to remember, 10% dextrose, 100 ml content, 10 gram. So it is in 5% dextrose, 100 ml content, 5 gram. Osmolarity, obviously dextrose content is less, it is 252, and it is a hypotonic fluid also. Very rare use in day-to-day pediatric practice, but for preparation of different fluid, or if sometimes if you are calculating glucose infusion rate in neonate or in hypoglycemic patient, or where you are restricting fluid, you are calculating how much glucose is going, how much calorie child is receiving in especially ICU care, you have to remember this much only, that in 100 ml we have 5 gram of dextrose, because it is percentage is there, 5% means in 100 ml. Next, easy to remember is DNS. What is this? Dextrose, 5% dextrose and normal saline. Very easy to remember. Dextrose 5% means, and that is in 100 ml we have 5 gram dextrose or 5 gram glucose, and it is other composition is almost same like normal saline. That means in 100 ml you have 0.9 gram of sodium chloride. That means 154 millimole per liter of sodium, and chloride 154 millimole in 1 liter of fluid. So it is a combination of dextrose and normal saline. So for easy to remember, we'll start with 5% dextrose. It is 100 ml. In 100 ml, 5 gram. In normal saline, we have 154, 154. In dextrose, it is a combination of just 5% dextrose and normal saline. It is a bit of hyperosmolar, but tonicity is almost near to plasma. Sometimes we may need N/2 5% dextrose. For easy remember, dextrose is here in 5% and the sodium chloride content is half of normal saline. So in this, sodium is half of normal saline, that is 77 milliequivalent per liter or millimole per liter of sodium. Chloride also half of normal saline. It is 0.45% or half of normal saline. So 77 millimole per liter of chloride. Dextrose content is similar to 5% dextrose. That is each 100 ml contain 5 gram. Very rarely used. Though osmolarity is high, it is hypotonic. So sometimes when you are correcting hypernatremia, if the sodium is not following accordingly your plan, so we may use this as a IV fluid for transient duration, but for common purpose, the use is very, very restricted in day-to-day practice. Till now, the fluid, whatever I discussed, does not have any potassium. So the first fluid we're going to discuss is Ringer lactate. For remembering purpose, this is the fluid, first fluid which we are discussing now contains potassium. Its sodium is a bit of lesser than normal saline. So if you remember that as a 150, here it is 130 milliequivalent per liter. For easy remembering, 150, 130. Potassium, 4 milliequivalent per liter. Chloride also lesser than normal saline. So in normal saline, chloride is 154. Here it is 109. It is lesser than 110 for easy remembering. 150, here 110. Sodium is 130, chloride is 110. It also has a calcium and lactate. This lactate helps in buffering. If your liver is intact, this lactate helps in buffering. Its osmolarity and tonicity also close to plasma. So normal saline and Ringer lactate is the example of isotonic fluid, as Agni sir also discussed. Next come Isolide P in 5% dextrose. All of us remember Isolide P, but for easy remembering, if you remember, it is Isolide P in 5% dextrose, or it is a multi-electrolyte injection. One of the example of multi-electrolyte injection. That means in this Other than norm sodium, chloride, potassium, you have few more electrolytes. So its dextrose is just same as 5% dextrose. Its dextrose is just same as DNS, 5 gram in 100 ml. Sodium content, very less, 23 milliequivalent per liter, because you are using in newborn. That is why it is sodium content is very less. As Agni sir is telling that the use is almost abundant, except in newborn, because their sodium handling capability of kidneys are not as compared to adult or older children. It has higher potassium content per liter. Chloride is also very, very less, 30. Just to remember round figures, 20, 30, 110, 150, 130 like this. So chloride is almost 30. It also has magnesium. It is a multi-electrolyte injection. It has acetate as a buffer. It is osmolarity is same, but it is again a hypotonic fluid. Now comes balanced solution. That means in this solution, everything is almost balanced. The composition are almost near to our body's fluid and electrolyte composition. It has fewer adverse effects because it can buffers also. Less chance of hyperchloremic metabolic acidosis because chloride content is less than normal saline. Normal saline chloride content is 150. Here chloride contents are less. Because of this hyperchloremic acidosis, it is not there, or less chance, it is less chance of causing acute kidney injury and inflammation, because chloride is not a simple molecule. Day by day, many researches are going on to show the adverse effect of chloride. So this hypothesis was when plasma light use was started, though subsequently many researchers shows that the benefit is not very, very high when compared to normal saline or other isotonic fluids when we are using, and it is costly. So what are the composition? What are the different types of balanced salt solution? Remember, the basic understanding of balanced salt solution is all the components are near to our normal body composition. So commonly used thing is plasma light A. Sodium is 140. Whatever the other name as they are, like normosol, isolate or ringus acetate, these last three are not commonly available, but their sodium component all are almost similar to what is sodium rich. Potassium 4 to 5. So commonly used is plasma light A. Its potassium is 5. It also has magnesium. See the chloride content of this. It is 100. If you remember 100, round off, it is actually 98. But if you remember 100, it is almost 50 lesser than normal saline. So if you push normal saline 2, 3, 4 boluses, the chloride content will go very high. In this, if you give, the chances of hyperchloremia is less. Another beauty is see the acetate gluconate. These three things helps in buffering. So in metabolic acidosis, even if the liver is not functioning, this acetate and gluconate can help in maintaining your pH towards the normal status. If you give RL, it has to get converted from lactate to acetate or bicarbonate by lactate to bicarbonate by liver. But here, even in liver failure or in liver injury, you can use this and it helps in buffering. And the last column, if you see, it is almost the osmolarity is close to our physiological osmolarity. So summarizing our commonly used IV fluid or commonly used crystalloids, let's look at normal saline first. 154, 154, nothing extra. Sodium 154, chloride 154. DNS, just a combination of 5% dextrose and normal saline. So sodium and chloride content is just like normal saline. Extra, it has 5 gram per 100 ml, or per liter it is 50 gram. Per 100 ml it is 5 gram, 1 liter is 50. Simple equation. If we go to N/2 5% dextrose, just half of normal saline. So sodium and chloride is half of normal saline. Dextrose is as same as 5% dextrose or DNS. Isolate P, dextrose concentration is same as DNS or N/2 5%, but its sodium content is extremely low. It has more potassium. RL, sodium content and chloride content is lesser than normal saline. It is almost near to plasma line. So this is one of the cheapest balanced solution is RL. It also has potassium, calcium, and lactate convert to bicarbonate, helps in buffering. Its osmolarity and tonicity is similar to our body. So it is one of the cheapest isotonic fluid or cheapest balanced solution. So once we finish the crystalloid, we'll go through we'll go spend some minutes in colloids. When you are prescribing colloids or you are thinking of colloids, you have to understand few basic things, that it stays in intravascular volume for more than period than crystalloid. But if it gets leaked to extravascular space, it also draws water from intravascular space to extravascular space, so may lead to pulmonary edema in AKI or acute kidney injury or other critical AHI. So commonly used colloid we use in our albumin. Different concentration of albumin is there. Simple difference with crystalloids are it remains more in intravascular space. It is half-life is longer. Crystalloid rapidly shifts from intravascular space to extravascular space through semipermeable membrane. So it stays less than in intravascular space. Hence, larger volumes needed. For colloid, you need less volume. The chances of edema more with crystalloid because it sips out. The chances of anaphylaxis are there with albumin because it is a blood product and it is costly. There are several colloids are available like hemcell, gelatin, starch, but the chances of anaphylaxis are more than albumin. So hence commonly used colloids are albumin. It also has a good quantity of sodium. If you see the last column, the sodium content is almost 150. So even if you are using albumin, you are diluting 20% to 5%, or directly if you are using 5% albumin, you have to keep in mind that it can alter the sodium homeostasis too. We have two strengths commonly available, 5% albumin, 20% albumin. The same formula, whenever you have percentage, you think about how much in 100. Something there, 100 is there. So 5% albumin means in 100 ml of this fluid, you have 5 gram. So in 1 liter, you have 50 gram. If you see 20, in 100 ml, you have 20 gram. If you see here in the bottle, the liter has 200 gram in 1 liter. So 1 liter, you have to just multiply by 10. Commonly used indications, common for albumin, fluid resuscitation in the later phase, rarely, sometimes in dengue. Once you are giving crystalloids and the patient is not improving, you can use. Significant hypoalbuminemia is there in malnourished state or already in a malabsorption state. Nephrotic syndrome, sir has already discussed. If you are using plasma exchange for different conditions like autoimmune encephalitis, HUS, in that as a replacement fluid colloid is there. Other are post-surgical, if there is drain losses are there. In cardiac unit, sometimes the drains are more or chylothorax losses are there, in that they use.
Dr. Rohit, we have 4 minutes more.
Over, sir, 2 minutes more. So customization of IV fluids, or in emergency, do we really need this preparation? As of now, we can get this customized fluid from pharmacy, or it is better to ask your inbuilt pharmacy to make it. If it is not at all possible, then you can keep this a simple chart that I will share to prepare or customize the fluid. But even if you see in this chart, it is very easy to prepare some fluids. Let's start with the simpler one. If you see N/2 5% dextrose, the most easy to prepare. What is this? It is N/2. And if you think 5% dextrose as a 10/2, so it is N/2 and 10/2. So you mix same quantity of normal saline and 10% dextrose. So it will become N/2 5% dextrose. Very easy to prepare. Next, whenever you want to prepare some dextrose, like if you see the bottom 2.5, 5, 10. Just give same quantity of dextrose and simple free water. These preparations are mainly needed when you are giving anuric regime or in decay diabetic ketoacidosis, when the sugar containing sugar level are fluctuating and going to the hypo range. Those we will deal in the fluid management of decay. So I'll share this chart, and different formulas are there. You have to, if you remember the basic concept of 5% dextrose, 10% dextrose, normal saline, then you can customize and prepare by just removing a small amount of fluid from this to and then. And also you can add soda bicarb if needed to maintain the sodium content in this customized fluid, or you can add 3% NaCl2. Do you have any guidelines for fluid? Yes, there are many guidelines, like NICE guidelines are there in UK, AAP guidelines are there. And for critically ill child in ICU and emergency, the recently published guideline from European Society of Pediatric and Neonatal Intensive Care, they published last year only. It is freely downloadable, and you can see just the recommendations are there in few points, in few boxes. The recommendation are there. No need to read the full article. It is very easy and day-to-day practice. You can use this article. So in summary, the basic concept of IV fluids are divided into crystalloids and colloids. Among crystalloid, you have isotonic, hypotonic, and hypertonic fluid. For practical purpose, we use isotonic fluid. For your day-to-day practice, crystalloids are commonly used IV fluid. Colloids can be used or indicated in special circumstances. Remember, IV fluid is a drug, and the few basic IV fluids you keep in mind with that formula. 100 ml, how much percentage is there? Round off all, like 150, 130, 110, 77, 5, 10, 25. If you remember only these 5 or 7 numbers, life will be easy for you. And lastly, whenever you are prescribing IV fluid, it is a teamwork. You have to write the drug. Your nurses or your junior staff or your other ICU members will give the drug. You have to monitor, see how much it is going. They should also understand what you are writing. If you are mixing this different composition of IV fluids, many a time they get scared that you are mixing 5 ml of this, 3% NaCl this. So try to avoid all as much as mixing as possible, and explain them why you are giving, so that they can understand the changes, especially in decay when you are changing frequently fluid, to tell them why you are doing. So it is a teamwork, and if you are doing perfectly, the patient outcome will improve. Thank you again for WAP for giving me this opportunity, and I'd like to answer any questions if it is there.
Thank you, Dr. Rohit, for your crystal clear presentation. In fact, I was amazing. It was amazing and I was amazed. But you have to give some answer to the questions that has come. What is the exact age when we transit from half DNS to full DNS for maintenance therapy?
So again, a very easy question to answer that, as Agni sir also said, that half DNS role is almost nil. So up to, there is no exact age is there. So ISOP for neonate, then you slowly go to N/2 5% dextrose. Nowadays they say you just start with dextrose normal saline and add potassium, as we already discussed, after some time. Acutely ill child, AKI, you don't know the potassium status, you can wait for some time. So there is no clear exact age when to shift. But yes, up to 6 months, many people prefer N/2 5% dextrose. Otherwise, DNS, you can blindly start, monitor it. Remember, in ICU or critically ill child, you start and monitor what is happening. Then you can customize, you can modify. There is no exact age that up to this N/2 5% dextrose, after that DNS. DNS is now preferable. Many unit, if fund is not an issue, balanced solution also they are using.
So, sir, why do you prefer the hypoosmolar fluid for initial resuscitation in the SAM children in malnutrition?
Okay, excellent question. Hypotonic fluid in SAM. We have a session on SAM. Please keep this question in Dr. Manas will take care, diarrhea and SAM.
Okay.
Yeah, actually, you can answer it also. Cells are atrophied, cells are atrophied. And if you give, and the hormones are high, cortisol and all. If you give the normal saline or all, there will be a heart failure because the capacities of the low heart is and all. So always we start with the hypotonic saline in by 2GS.
Yeah, so thank you, ma'am, helping. So at the disclosure only, I tell that special situation we will discuss in next 2 days. Okay, sir. Next question, sir.
Yes.
Which albumin, 5% or 20% indicated for nephrogen? I think he missed the first session.
Yeah, Bagga sir already discussed this.
Already discussed.
5%, usually 5%. If you don't have 20%, 5% is safer. Give it because more if the load if you give, suddenly heart failure, pulmonary edema, all this can happen. All Bagga sir already discussed this in very nice.
Regarding the complications like osmotic demyelination, which play major role? Pathophysiology, or is it osmolarity or tonicity? Which one? Osmolarity or tonicity?
It is mainly osmolarity, and again osmolarity, tonicity number. It is not all. Mainly we have to monitor it. If you start the fluid, just formula and leave it for 12 hours or 24 hours, then chances of this disequilibrium or demyelination all will happen. So for the learning point, as we learned from our seniors, professors, if you are treating hyponatremia and hypernatremia, start the fluid. If you are treating hypernatremia, start 1.5 or 1.25 maintenance. Then you monitor 2 hourly, 6 hourly. Even this is 2 hourly monitoring is also needed because your fall should not be more than 5.5 milliequivalent per hour. Right now they are reducing. So 24 hours, the fluctuation should not be more than 12. Now reduced to 8 to 10. Sir, Agnes sir already discussed. So you have to monitor closely. Don't just start and 24 hours or 48 hours wait. It will all these disequilibriums and CP, central pontine myelinosis, will happen. So you have to closely monitor. Here the osmolarity help mainly trigger the factor.
Any role of N/5 solution in AKI?
Okay, again N/5 purely no, but sometimes if anuric regime and replacement N/5 plus 5% dextrose, that also will be discussed in details. My colleague Aditi only will discuss that. So he is preparing very nicely. It will be dealt.
Any in neonates, adding of crystalline amino acid in IV fluid preparation has any impaction in the fluid composition, sir?
Crystalline amino acid in IV fluid preparation. So you are going to TPN or partial PPN. Again, first disclosure is I am not a neonatologist, but again by general practices, why you want to mix your aminoven will go in a line different. If you are giving lipid, it will go in a different line, and in the same line you can mix later also. So yes, it can disturb, but you are calculating. When you are TPN, you are calculating day-to-day basis based on your previous value and what is your goal on that particular day. So TPN is a calculation for day-to-day basis. Sometimes 12-hour basis also TPN you have to modify.
So thank you, Dr. Rohit, for your excellent presentation.
Sir, we have one more question in QA, I think. Sapon sir, we have one more question in QA, I think, from Dr. Sujay Chaudhary. When we will give colloid in shock?
Well, I cannot find it.
Colloid in shock. So if you see the last survival sepsis guideline, it is level 2C recommendation. So last, avoid as much as possible. Start with crystalloid. Nowadays, initially they go to high fluid. The recent all guidelines, they are reducing fluid 20 to 40 ml, initially 20 ml per kg, 10 to 20 ml depending upon ICU they are or not, 15 to 20 minutes slow. So as less as possible, better to avoid if you don't have ICU care. No clear cut answer till date, but yes, sometimes after 60 ml per kg, many people uses. But guideline says level 2C, better no routine use. Last 2022 guideline.
Okay.
M cell or albumin? Yes, albumin is better because M cell very few people use.
Okay.
Agni sir
And
can
one
answer
fluid in-
himself.
Over to you, Sumantra, for the next session.
Okay. And another question was in AGN with hyponatremia, which fluids should be given. I think the nephrotic part is dealt with Vagga sir, and for AGN, mostly high SIDH and hyponatremia usually doesn't merit. Usually there is hypernatremia. In case, any case, it will be dealt with the renal part with AKI on day 2. So
Yes.
by this, we can move to our sessions to our next talk. And thanks, Dr. Rohit, once more for the excellent deliberation. And
Thank
now
you.
we can call upon our one of our favorite colleague, Dr. Satyabrata Roy Chaudhary. So just excuse me for sharing the screen. So Dr. Satyabrata is in. I hope my screen is getting shared. Sir, can you please ensure once?
Yeah. It's coming.
Its
It's coming.
written screen is paused.
But it's.
I think I need some permission from Somnath or something to share the screen.
Somnatha, please allow him to share the screen.
I can't.
So the topic is the monitoring of patient on IV fluid. So I request Dr. Satyabrata Roy Chaudhary to share.
1 minute, sir. I think there is some.
Dr. Roy Chaudhary can start it.
No, sir. We are from the same device. Just a minute. Just wait a minute, sir. Just give me 1 second. Sorry for the technical glitches. Just a minute waiting time. Yeah, here we go. Just 1 moment, sir. Sorry, sir. Extremely sorry.
No, it's okay.
Yeah, sure. I can't find out. Share screen. Share screen.
Yes.
Is it loading now, sir?
Yeah. It's showing, but make it a full screen.
And is it full screen now?
It will come. Yeah, perfect.
So now can I request our colleague Dr. Satyabrata Roy Chaudhary, who is in charge of pediatric ICU North Bengal Medical College, and to take over the dais. Thank you.
Very good afternoon, everyone. Today was a busy day, and we have from the evening we have learned all about different types of fluid, how to give maintenance fluid, everything. Now this is a very practical part. This is a monitoring part, and I think we can go with this with a simple case. It is a very common case. A 5-month-old male child admitted in our PICU with a septic shock, ARDS, DIC. Child was resuscitated and ventilated and put on IV fluid. Pre-illness weight was 6.5 kg and NG tube drainage was 50 ml. And child was on adrenaline at 0.2 microgram per kg per minute. So injection ceftriaxone and vancomycin added, and eptoin was added to give control the convulsions. So we have to write a fluid prescription for this child. So when we have to write fluid prescription, we have to look for the maintenance fluid, replacement fluid, redistributions, and resuscitation fluids. So we have to we have to clearly write a prescription with a clear signature, date, and time. And for that, we have to calculate the maintenance fluid. And we know to burn the 100 kilocalorie, we need 100 ml fluid. That was the basis of the holiday sagar, age-old holiday sagar formula. And this is the age-old formula, and Dr. Ognish sir already told us that it has many flaws, but till date we have not found any alternative to this formula. I am not going to details how to calculate it, as you have learned already. So for our child, it is a 6.5 kg old child. Our total fluid requirement was 650 ml. So we have written a prescription of 650 ml DNS over 24 hours with a KCl 1 ml per 100 ml. Now, is it okay? So for writing prescription, we have to keep mind the child is all on different medications, and that is also adding the fluid. So we have to deduct them. We have to add any ongoing loss like nasogastric loss or diarrhea or vomiting. So we have to correct it. So now we have corrected our prescription. We have deducted the fluid for adrenaline, vancomycin, eptoin, and added the NG loss, and correct fluid is 596 ml. So ongoing losses are very important, and we have to replenish it 1:1. So what are the ongoing loss? They may be the vomiting, diarrhea, diuresis, nasogastric suctions. Sometimes they are very difficult to measure, like vomiting, measurement of diarrhea, they are very difficult. So sometimes we have to give we cannot measure actually, so we have to estimate it, like 10 ml per kg body weight for watery stool and 2 ml per kg body weight for each episode of emesis. We can add fluid. So every time we are putting a child on an IVF, we have to do a thorough follow-up of the child. Depending on the clinical condition of the child, we have to set the frequency. If the child is critically ill and admitted in PICU, it needs more frequent monitoring. But if the child is in ward and stable, then we also have to monitor the child at least twice a day. So basic clinical parameters like heart rate, respiration, blood pressures, saturations have to be monitored. So after 2 hours, we have found that our child is desaturating, and chest on auscultation, there was capitation in the chest. So what happened? So there may be when we are providing IV fluid to a child, it may be inadequate. So the child may not getting the replacement of the every losses. So there may be signs of fluid deficit like restlessness, irritability, sleepy, lethargic, shrunken eye, thirsty, skin pinch go slowly, and decrease urine output. And there may be signs of shocks like rapid pulse, cool and blue extremities, hypotension, and rapid breathing. On the other hand, there may be signs of fluid overload like weight gain, desaturation, edema, new onset breathing difficulty with crepitations, and increase in liver size. So what happened in our case? Our child is showing the signs of fluid overload. So whenever we are detecting signs of fluid overload, we can go for some advanced monitoring, like functional echocardiography. Bedside echocardiography can give us a clue about the cardiac chambers, dilatation of the cardiac chambers contractility, and we can do IVC collapsibility estimations, and we can go for lung USG. So we can see that if there is a confluent B lines or increase in the number of the B lines, that means the child is developing pulmonary edema. So child is in fluid overload. So what went wrong? We have to review our case. And after review, we found out that the nursing staff was confused about the rate of the fluid. And he almost infused half of the fluid over 90 minutes. So why this happened? So how to prevent such accidents? So we have to write complete and clear fluid prescription. Mention the type of fluid, amount, rate of infusion. Handwriting should be clear. If any electrolyte to be added, should be mentioned clearly. Use double check methods to prevent any unwanted errors. So we have to stabilize our child with a Lasix, and we corrected our prescriptions. And this time we have written the fluid rate 25 ml per hour. But nursing staff, the attending nursing staff complained that she was not able to give 600 ml fluid at a time. So we have to break it down. We have write down it differently, 300 ml with 3 ml KCl over 12 hours at a rate of 25 ml per hour. So we have to communicate with the endpoint care deliverer. So the nursing staff was not, if she is not comfortable with the order, she may can do mistakes. So we have to see that she can understand our order or not, and she has the capability to follow up it or not. So So another important aspect is that we have to review the clinical conditions and other predisposing conditions. We in the morning, Dr. Shekhar or Dr. Ognisar already have told us about the SIDH, so I'm not going in details about that thing. But like pain, pneumonia, CNS infections, these are predisposing cause for SIDH. So if there is SIDH, if there is fluid accumulation, we have to restrict fluid 50 to 80%. And if there is heart failure, we know the child is on myocarditis or some congenital cyanotic heart, congenital heart disease with failure. We have to restrict fluid for 50 to 80%, depending on the condition of the child. If the child is in renal failure, we can estimate the fluid on the basis of the body surface area, 300 to 400 ml per meter square over 24 hours plus urine output. And if the child is fluid overloaded, then we have to restrict the fluid. So in our case, that our child is fluid overloaded, so we decided to restrict the fluid. So now we have restricted our fluid, and we found that with this 80% restriction, our fluid is 480 ml. So we have given the order like that. Now on day 3, we found our child is grossly edematous, respiratory parameters deteriorated, child is gaining weight. So body weight estimation is very important. But what happened in our PICU, sometimes we are receiving critically ill child, and actual body weight estimation is very difficult at that point. So we sometimes derive body weight from the length or from the age. But whenever possible, we should get our actual body weight. It is very important. And in case of small children, and if we are capable, it is feasible, and we are trained properly, then we can do regular body weight estimation of critically ill children also. And if in regular estimation we found that there is a regular loss of the body, the child is losing body weight, that means we are not adequately replenishing the losses. So mild dehydration means 5 to 6% loss of body weight, moderate dehydration 7 to 10%, severe means more than 10% loss of body weight. But sometimes when we are putting a child for long term on IV fluid without any TPN, child will lose weight due to muscle losses. And in case of pediatrics, we can put our children up to 7 days without TPN. But if there is a gaining of body weight, especially if, in newborn and neonatal age group, if there is initial few weeks that baby usually lose weight, but that loss of weight is not happening and child is gaining weight, that means the child is developing fluid overload. Urine output is another parameter that has to be monitored keenly in case of children on IVF. The frequency of monitoring depends on the clinical condition. If the child is hemodynamically unstable, we monitor more frequently, even 2 hourly. Depending on the condition, we can do it 4 hourly, 6 hourly, or 12 hourly. Then what we have to do, we have to estimate the fluid balance. What is the fluid balance? Total intake, IV, oral, medication, everything, minus total output. Urine, stool, vomiting, drain output, and even the child is on any renal replacement therapy, that output has to be added also. So fluid balance, usually we have to total fluid balance at the end of 24 hours, but sometimes in critically ill children, we do a subtotal fluid balance at 12-hourly basis. So this, we have many studies have shown that increase in fluid balance is associated with adverse outcome. But optimum method to determine this fluid balance is not well established. More than 10% fluid overload associated with significant vulnerability. So there are some formulas that are weight-based formula and some are fluid-based methods. So when to choose what? So in case of small children, like newborn children, where body weight estimation is easy, we can and output estimation is difficult, we can choose the weight-based formulas. But in case of children where urine output estimation is easier than body weight estimation, we can choose the urine output and fluid-based formulas. Okay. But if you look at this site, this slide, you can see there are two patients. These are adult patients. Patient 1 is receiving 6 liter fluid, and there is a 15% capillary leak, and fluid balance estimation was urine outputs was 60% and fluid balance was 2 liter 400 ml. But in patient B, there is child has the person has been fluid restricted, so receiving 3 liter fluid, and this huge capillary leak, 55% capillary leak, and 20% fluid output. But in this case also, fluid balance is same. So in both patients, clinical scenario is not same. But if we bluntly do the fluid balance estimation, it is same. So in what can we do in these situations? Because we can do something called fluid accumulation index estimation. Here, fluid balance is divided by the fluid intake, and we can derive this index. You can see the second patient, this fluid accumulation index is high. That means there is more capillary leak, and this is associated with more adverse outcomes. But this index is not, I think, not used in pediatrics very much. This is mostly used in adults. So we have to wait to test the utility of this index. We have to wait for proper studies. So now we have to review our case. We have estimated urine output. It was 0.8 ml per kg per hour, and total urine output was 125 ml over 24 hours. Now we are estimating total intake. What was we have restricted? If you remember that in our children, we have done a 80% restriction of fluid, and that fluid was 480 ml. So 480 ml IVF, and the resident given 65 ml of blood transfusion, and the child required noradrenaline infusion. So noradrenaline was added, and midas fentanyl was also added. So now we found that total intake was 721 ml, and child's weight is 6.5 kg. So actually what is happening? We have done 80% restrictions, but child is getting more than 100% fluid. Now fluid balance is also high over 24 hours. So what went wrong? So we have not done daily fluid balance, and fluid advice was not updated daily. Drugs, bolas, blood products were not adjusted on daily basis. This has to be done daily basis. Okay. So now we have restricted our fluid to 60%, and with all adjustment, it was 280 ml fluid. Injection Lasix was given, and we have done CBG estimation 480 milligram per dl, sodium 124, and potassium 2. So investigations. So when we're putting a child on IVF, we have to do some investigations like regular basis, like blood count, urea creatinine, plasma electrolyte, blood glucose. Electrolytes have to be done on daily basis. On every day, you at least one time you have to do a electrolyte estimation, because when we are putting a child on IVF, there is high risk of dyselectrolytemia. But it can be done more frequently depending on the clinical condition of the child. Blood glucose is very important. In small children, there is a high risk of hypoglycemia. I am not going in details of hypoglycemia management because it is not my scope here to discuss. But another thing is also very important. There is hyperglycemia, as that happened in our child. Our child CBG was 450. Hyperglycemia is equally harmful than like hypoglycemia. So we have to treat that also. So what we can do? We can reduce the glucose content of our fluid, and we have to remember for working for our regular practice, we usually target 180 milligram per dl blood glucose level, but targeting too low may risk a risk for hypoglycemia. So now what we have done, we have continued this fluid restriction. KCl has been added, increased in our fluid changed to NS for the time being, and 6-hourly CBG monitoring continued. Complete hemogram, urea creatinine was repeated. So another important thing, whenever nursing, it is about the nursing care. Whenever whenever fluid is changed, we have to examine the site, channel site. We have to see for if there is any sign for inflammation, extravasation, any signs of thrombophlebitis. We have to remove it and do a fresh line. Another important thing is that inotropes should be infused through a separate port of central line uninterruptedly. Bicarbonate and calcium should not go along with the inotropes. If the fluid contains bicarbonate and calcium, it has to be transfused through separate line. So on day 5, what we found that respiration and hemodynamic child was respiration hemodynamics parameters are stable still on IVF, and one failure attempt of extubation was done. So what we forgot. So whenever we are putting a child on IVF, it is our duty on the daily round to find that the child is capable of starting enteral feed or not. If there is no hypoxia, if there is no GI bleed, child is hemodynamically stable, no other GI pathology, as soon as possible, we have to start enteral feeding. Because enteral feeding is associated with VAP prevention, successful extubation, and lesser PICU days. So I complete my presentation here. Thank you for this opportunity.
Thank you, Dr. Rai Chaudhary, for your interactive session with the case presentation. Now, few question has been answered by Dr. Rohit Bhomik. I think some questions are still there. So, what is the meaning of dry weight of the PQ in that formula? So,
dry weight is important in case of when we are obese patient, hugely obese patient we are dealing with, then we can estimate dry weight, but in actually daily basis, we don't estimate dry weight, and we usually estimate the actual weight based formulas.
So, I think most of the questions are answered by Dr. Bhomik. So now over to Sumanto. Sumanto?
Yes, sir. Sir, there are, I think, few more questions, one or two questions. Most reliable method to calculate BSA. Dr. Soto, do you want to answer? Most common reliable method to assess BSA, body surface area.
Body surface area.
Though probably not in the purview of this talk.
Yes, the body surface area can be calculated with different method. There is height-based methods are there, and simply there are some mobile apps also where you can input that things and body surface area will be given. Okay, so these things are not problem in our PICU. These estimations and these things, mobiles and other applications have made our life.
One question is there from the basis of the inotrope, single infusion pump versus different infusion pump, and multiple in case of multiple inotrope. Was that answered?
We should use different infusion pumps, but separate and single port should be allowed, because if we attached that in same port with fluid, so whenever the sister is changing fluid, inotrope will get interrupted. That should not happen. Whenever inotrope is interrupted, there may be hypotension and other things. So we should not interrupt the inotrope lines. Okay, but inotropes
yes,
should
Dr.
be mixed
Rohit
in
has
separate.
answered. So
regarding Dr. Avish's question, most reliable method is most likely the Mosteller formula we usually use in our pediatric nephrology ward for calculating intracranial dose and others. That is height into weight divided by 1600, that is square root. That is Mosteller. You can jolly well get in the Google also, and
Yes,
Dr.
yes,
Dr.
yes,
has
yes,
told
yes.
it is also available in the app-based formula. So
Yes.
if you have a
App-based
smartphone,
formulas.
you can do it app-based. Next, any more questions, sir? Satto, can you check once?
Oh, where Mihir is getting the questions, I cannot see it. Because no, nothing. No, I cannot see any other question.
That's fine, sir. Most of the QAs are being answered
I
also.
think the questions are answered.
No,
Yeah,
one,
yeah.
one question on potassium, 1 ml of potassium to 100 ml.
He has answered.
Rohit
Dr.
has answered.
Rohit has already answered.
Okay.
It has already answered
So,
clearly.
so now, sir, it's
I think we should conclude the session today.
Yes.
Because
Yeah, time is also
time is also over.
so very. First of all, thank all the speakers to finish in a time. No, they are so punctual and so very nice presentation.
I mean, one more thing for all the attendees. If some attendees have registered for this program, has joined today's program, but not in the part of our attendees WhatsApp group where we are going to share some of our question and answers. So you can contact Mr. Somnath of WAP. The number is been shared in the chat box, and they will be included in the WhatsApp group from next day onwards, tomorrow onwards.
Request
Ma'am,
you
what do you
all
want?
the panelists to just open their video to take a photograph. Just
Unfortunately, we have a power
That
cut
is
now
important.
in our MMC. Me and Satya stuck in a room.
We'll take on the final day.
No,
We'll
not
take on the
possible. It's also
final day.
possible, sir. Let us try. Let us try. Yeah, that's fine.
এই যে অন্ধকারে বসে আছে সত্য আর
Power cut, madam.
পাওয়ার
That's
কাট
why-
ইমার্জেন্সি লাইট ডাকুনি ওখানে ইমার্জেন্সি লাইট ডাকতে হয়
এখানে তো পাওয়ার কাট হয় না হসপিটালের ভেতর
বাঁকুড়ায় ওই দুটো ইমার্জেন্সি লাইট
ঝড়টার হচ্ছে
Actually, I was listening to Dr. Satyabrat Rai Choudhury from Dr. Sumanto Rao.
yeah, we are in the same room.
We are using the device interchangeably.
Yeah.
That's
Now
fine.
I can
Okay.
see the
Me,
Manus
take the
after a long
snap.
time.
Take the snap.
Yes, and after a long time seeing the Shotto and Manus.
Thank you.
I'm really happy to see you people.
Okay, done.
Anyway, so should I conclude?
Yes.
So
Thank you, sir.
It's a very excellent presentation by all the faculties. As this patient mentioned, Dr. Baka, who was agreed to join, and Dr. Ogni Shekhar Shaha, Dr. Rohit Bhomi, Dr. Satyabrat Rai Choudhury. And I think all the delegates are being benefited because it was totally an interactive session. All the questions we have tried to answer. And I will request you to log in proper time tomorrow at 6 p.m. So we have got some interesting sessions also. So please log in time and have a wonderful learning session for the next 2 days. And thank you everybody, and particularly special thanks to Dr. Mihir Sarkar and Dr. Sumanto Rao. They have put so much effort.
And Dr.
And
Rohit also for
Rohit,
that
Rohit,
app.
yes.
We are waiting for that wonderful app.
That magic day.
Yes, ma'am, it will be
on the
nice.
last
Magic day on Sunday.
Yeah.
Okay, ma'am.
So,
Thank
you know,
all the attendees
actually,
also for staying so
I
long
just-
till 8:30.
I just remember two sayings, morning shows the days. So the first session was so good, and the another saying said the all is well with the ends well. So everything is so good from the morning, first session to the last session, and so much learning and so much, informations, and in a simplified way. That's very good. I think all the participants have a very good time and they have learned a lot, I think.
Okay,
good night,
tomorrow have
everybody.
another legend with